Okay, hello, good evening. Today our second recall in our revision for April 2, 2020. We will start as we used to. Let's start today Fawzia sheet 2. As again, I'll say Fawzia sheet is 1 and 2 are the most important recall you have. The most important till January 2021, many scenarios with the same word, with the same options, with the same order of options. So please, and it's the basic for any other recall we will study. We have Fawzia sheet 1, Fawzia sheet 2, April 2018. We have some complete scenarios from September 2020, from January 2020, and many complete scenarios from January 2021. These recalls are the basic for your other recalls. Other recalls were not available as complete scenario, but we could complete it from our minds as we start reading the scenario. We will know, yes, this Fawzia sheet 1, this is April 2018, this is so we can know the full scenario, and by time we can know every question till we reach many recalls which is not completely was not complete scenarios, but from the first two words in the scenario you could give the answer and you could imagine the complete scenario. Okay, yeah, let's start. Dr. Tak, تفضل.
Okay, hello.
Yeah.
Okay, is it clear? Everyone can listen?
Sorry?
Is it clear? Is my voice clear?
Yeah, voice clear. Sorry, what's your name?
Taki.
Dr. Taki.
Said,
Yeah, Dr. Taki.
Said Taki, yeah. You can call me Said.
Dr.
No
Said.
problem.
Okay,
Yes,
Dr. Said.
no problem.
Okay, Dr. Said. Okay.
Yeah, sounds better. Okay, yes. All right, let's start with number 1. Okay, a 26-year-old man motorcyclist loses 1 liter of blood secondary to an open fracture of the femur sustained in a road traffic accident. Which of the following is the most likely earliest compensatory response in hypovolemia in this patient? So it's A, baroreceptor-induced vasoconstriction.
Okay, this is one of the, by the way, you'll find many scenarios, maybe repeated from Fawzia sheet 1, maybe with the same scenario or just changing some words in the scenario, but with the same idea. Okay, because so we can go through this so fast. We said last time that in the first response in hypovolemia or in hypotension or in blood loss or hypovolemia or in intra-abdominal hemorrhage or any hemorrhage, and the patient went to hypovolemia, the first response is the mechanoreceptors. Then followed by the renin-angiotensin system. So this is followed by the renin-angiotensin, but it is not the first one. Yeah, okay, next.
Okay, number 2, histology of a discrete palpable lump in the breast of a 34-year-old woman has shown apocrine metaplasia, epithelial overgrowth, and papillary projections. What is the most likely pathological process? A, benign breast cyst.
Okay, this is young age woman, palpable lump, apocrine metaplasia, epithelial overgrowth, and papillary projection. What is the most likely? Okay, is there any signs here for cancer?
No, was never given a scenario.
Okay, is there any signs for infection?
No.
Yeah, no. There's
okay,
no signs.
So we have this is cancelled and this is cancelled. The picture of phylloid tumor and fibroadenoma and benign breast cyst. Okay, so he's apocrine metaplasia. apocrine metaplasia. So it is in the glandular cells of the mammary ducts, and epithelial overgrowth and papillary projection. This happens only on the benign breast cyst in this age. Fibroadenoma, it will be hard, this will not be cystic, and this is of the stroma. It is a problem in the stroma of the breast. The same like Pfeiffer's tumor. Okay, so very common question in this in the exam, and also it is in EMRCS, which is benign breast cyst. Apocrine metaplasia in a young woman equals benign breast cyst.
Okay, number 3, a 35-year-old woman presents with recurrent peptic ulceration. She is on proton pump inhibitor, previously received Helicobacter pylori eradication therapy 3 months ago. Which of the following is likely to be raised on venous blood testing? A, cholecystokinin, B, gastrin, C, histamine, D, pancreozymin, and E, secretin. So it's B, gastrin.
Okay. I think we have this question last time, and we said patient with a recurrent peptic ulcer, or we tell you the patient has resistant peptic ulceration in spite of full proton pump or recurrent or multiple proton pump blockers, the inhibitors the patient has received, even the Helicobacter. So this is gastrin, due to gastrin in Zollinger-Ellison syndrome or gastrinoma. And we have another question related to this question. We said, what can increase the gastrin release? What is the hormone causes release of gastrin? We discussed last time.
Secretin.
Adrenaline. Perfect.
Adrenaline, yeah.
So we have, yes, Akram, you can join. Okay, so we have the two adrenaline, increase gastrin in a way to increase the peptic ulceration. The other thing is increasing gastrin, Zollinger-Ellison syndrome or gastrinoma. Most of them increase gastrin, and gastrin increase peptic ulceration with patient resistant to medication. Okay.
Okay. Number 4, 33-year-old male boy presented with his mother for rectal blood loss. His mother describes it as a bright red blood in the toilet pan. He has no pain on defecation with negative family history. So what is the most likely cause? In view of his age, and it's painless on defecation, so probably could be juvenile polyp.
Juvenile polyp. As we said, we have a very young child. You have a very young child, you have two diagnoses. You have two diagnoses when you have blood, fresh blood, and sometimes he tell you the patient has a small fresh polyp or as a small pinkish polyp or fleshy pinkish tissue appearing from the anus during defecation and disappear after this. As very young age with blood in the stool, you have only two diagnoses, juvenile polyp, and the other one is Peutz-Jeghers syndrome. If he just tell you this polyp and just the blood, you will go for juvenile polyp. Okay, but if he tell you other manifestation of Peutz-Jeghers syndrome, you will go for it. You will go for Peutz-Jeghers syndrome.
But can we diagnose it at such a young age, 3 years old?
Yes, the mother will tell you, I have rectal blood. The Peutz-Jeghers syndrome, the patient with pigmentation around the mouth.
Oh, and yes.
The patient has, he will tell you there is pigmentation around the mouth, there is extra tooth, there is a sebaceous cyst, multiple sebaceous cysts or multiple desmoid tumors in the body. This is all Pett-Seeger syndrome. In the exam, he will just give you pigmentation around the mouth and tongue at the mucocutaneous junction, plus the polyp. What is the type of polyp in Pett-Seeger syndrome?
Hematomatous.
Hematomatous polyp. Hematomatous polyp.
Hematomatous polyp.
Okay.
Yeah.
Next question.
Okay. Number 5. So, 32 years old man presents with painful torticollis. There is no past medical history, and his only complaint is that he has been feeling rather tired over the last 4 nights. On examination, he has large rubbery mass in the lateral aspect of his neck, as well as a few small masses along his internal jugular vein. You correctly assume that the muscular neck spasm and the large mass are connected. The most likely cause of the torticollis is due to pressure on the D spinal accessory nerve.
Okay, we said spinal accessory posterior triangle torticollis of the neck. Related words, all of us can give any question about any. Which muscle will be affected? Sternocleidomastoid. Which nerve? Spinal accessory. What else?
The clinical examination.
Effect? Torticollis, and so on. Okay?
Okay.
Okay.
All right. Okay, number 6, a teen menopausal 52-year-old woman is diagnosed with breast cancer. Her menarche was at the age of 14 years old. She had her first child at age of 40 years old. During lactation, she developed breast abscess that necessitated surgical intervention. She has no family history of breast cancer. Which of the following is the most significant risk factor for this patient? A, age at first full-term pregnancy in view of her first child at age 40 years.
Okay. These are, I think this is very common question, and even in our bachelor degrees, that one of the risk factors of cancer, breast at age of first term pregnancy more than 35. More than 35 is one of them. Here is the risk factor, and here is the high risk factors. Age, طبعا, age of menarche, age of menopause, age of first pregnancy, it will be after 35 is a high risk factor, lifestyle and hormonal therapy as well. Okay.
Okay. Number 7, a 3-year-old woman is sent to the outpatient clinic with weight loss of 5 kg over the last 6 months. She also complains of anxiety, panic attacks, and palpitations. On examination, there is swelling in the anterior neck, which moves on swallowing. Which of the following is most likely pathology underlying this presentation? So basically, she has symptoms of hypothyroidism. So it's Graves' disease, A.
Okay, this young patient, weight loss, less than 6 months, she has anxiety, panic attacks, palpitation. Examination is a swelling in the anterior neck, moves or swallowing, which would the most likely. Can it be Hashimoto?
Hashimoto is normally hypothyroidism. No?
Okay. When you will see Hashimoto, it mostly will be hypothyroidism, because Hashimoto start early with a stage of hyperthyroidism, then go for euthyroidism, then go for hypothyroidism, and this is the permanent stage. Okay, this patient, mostly he will tell you the patient has other autoimmune diseases. Autoimmune diseases. Sometimes this patient have some pain in his neck.
I see.
Okay. The other طبعا METs, no. Papillary carcinoma, no. Any carcinoma, no. There is no cancer here. Never, even the age or any clinical picture can give us any cancer here. So all these cancer are excluded. And then we start to think about this. One is hyper and one is hyper. Next question.
Sorry, just want to talk regarding the antibody. For Graves' disease and Hashimoto is the thyroid peroxidase, right? Whereas the Graves is your thyroglobulin.
Thyroglobulin antibodies, thyroid peroxidase here.
It's just antibodies, eh? Okay, all right.
Yes.
Okay. Number 8, a 69-year-old man has been admitted to the high dependency unit following an anterior resection under general anesthesia. He has given 2 milligrams of intrathecal morphine. On examination, he looked pale and drowsy. ABG results are pH of 7.28, PCO2 of 8.1,
Comment
PO2
on
of
the pH.
10.2. Sorry?
Comment on the pH.
Oh, okay, sorry. pH is basically he's acidic, 7.28.
Okay.
Okay. PCO2 is 8.1,
CO2.
which is hypercapnia. PO2 is
Acidotic. Acidotic also.
yes, acidotic also, and then base excess is minus 2.1. Glucose is 21, and lactate is 4, which is raised. So in view of the PCO2 is high, the pH is acidotic, so it's most likely should be respiratory acidosis.
Okay. Here's from what he gave to us. He didn't give you HCO3. Okay. He didn't give you HCO3. Okay. He just bicarb. He just gave you the pH and give you the CO2. And this patient, anterior resection under general anesthesia, and he's given 2 milligram intrathecal morphine, and he looks drowsy, arterial blood gas. So one of the common complications of morphine is respiratory center depression. So the patient went to respiratory anesthesia. If we think about other things, okay, here is he want to confuse you. What he gave you? Glucose is high, so you can think about
metabolic acidosis,
metabolic acidosis, ketone bodies, diabetic ketoacidosis, but this is not the picture of ketoacidosis. This is not the picture of any metabolic abnormality. This is not respiratory alcoholism. The exam is so easy, by the way. If you look to this picture without the scenario, just if I don't have a scenario, and I give this table and tell you, choose here, what is this? You will get this without any scenario. Yes?
Yeah.
Okay.
Yeah.
Exam is so easy, so straightforward, not to think so much in the exam. Okay, next question.
Okay, number 9, a 32-year-old woman has pigmented lesion excised from her left calf. The histopathological diagnosis is melanoma in situ, which is completely excised with the 1 cm margin. What is the next most appropriate management? Discharge from follow-up and education about skin self-examination. A, yeah.
Okay, this is what you'll do after you remove and you remove it with safety margin. Show what you'll give to the patient or what you'll tell to the patient. Just will educate the patient about self-examination for any similar lesions. Next question.
Okay, number 10, a 60-year-old man with a past history of angina undergoes an uncomplicated operation for an inguinal hernia. Post-operatively, he is found to be hypotensive, tachycardic, and has raised JVP. What is the most likely underlying cause of his hypotension? A, reduced afterload, B, reduced parasympathetic tone, C, reduced preload, D, reduced stroke volume, and E, reduced sympathetic tone. So it's a reduced stroke volume. D.
What does this patient have?
This patient is basically, he is heart failure.
Sorry?
His cardio, he has...
He's in cardiogenic shock.
Yeah, he's in cardiogenic shock.
Cardiogenic shock.
Yep, cardiogenic shock.
This patient have a cardiogenic shock. In cardiogenic shock, the stroke volume is markedly reduced. So the heart just pumping blah, 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 with very little amount of blood. That's why the heart trying to make increase rate to preserve the cardiac output, but still the stroke volume is so low to high. But this is not reduced afterload. This is not reduced parasympathetic tone. This is not reduced preload. Reduced stroke volume. So there is congested, raised jugular venous pressure because the blood coming in the vena cava can't be pumped efficiently from the heart.
Okay. 11, a 4-year-old boy presents to the emergency department with a 2-day history of fever, difficulty walking, and is unable to weight bear on the right leg. He has been on oral amoxicillin 250 mg 3 times a day for a chest infection over the last 5 days. He is irritable with a temperature of 39.4. He does not allow examination and keeps the right hip flexed and adducted. Blood tests are white cell count is 18.3, CRP 146, hemoglobin 11.3. So what is the most likely diagnosis? A is AVN of hip, B, dislocation of hip, C, Perthes disease, D, septic arthritis, E, slipped upper femoral epiphysis. So based on the kosher criteria, white cell is high, CRP is also high. White cell is high, he has a temperature 39.4, and he has signs of septic arthritis.
The only one here, infection, is septic arthritis.
Septic arthritis.
What is this picture? As you said, this is a picture of infection, fever, pain, high white blood cell count, and very high CRP. Okay, CRP normal up to 6. All of this can give you constitutional symptom of infection. So simply I go for, what is this? Acute avascular necrosis? Nothing in the scenario, dislocation, no. Perthes disease, no. Slipped upper femoral. This is the only one septic arthritis.
But if they put a transient synovitis, then probably we have to
so
look
simple,
at the
straightforward question.
If there's an option of transient synovitis, then we have to look at the blood results. Hello?
Yes, sorry. Okay, continue.
Yeah.
To finish this question, sorry, I just have a call. Okay.
I was just saying about the previous one.
Very, yeah, sorry.
Yeah, the previous one, I was just saying that if it was, there was an option of transient synovitis, so then probably we have to look at the white cell count.
Transient synovitis has different scenario. First of all, the child will not show fever like 39.4, and the white blood cell and CRP will not see it. He will give you a history that the patient has pain, and 1 or 2 weeks ago, the patient has an upper respiratory tract infection, and patient received antibiotic and blah, blah, blah. This is septic arthritis. This is, sorry.
Transient synovitis.
Transient synovitis. Transient synovitis. Something, it will be something like autoimmune reaction after the upper respiratory tract infection. Okay. After the upper respiratory tract infection, because the antigens against the streptococci will misunderstand or misdetermine the joints or the antigens of the joints as a self-immune, something like this. You know, this is an autoimmune problem that will happen transient synovitis. Okay, and this happened after an upper respiratory tract infection 1 or 2 weeks ago, but not this picture. This picture is straightforward fever, can't with pain, very high temperature and very high CRP. It will be septic arthritis.
Okay.
Almost all, he will not confuse you and give you the 2 options at the same. Okay.
Okay. All right. Number 12, a 34-year-old man is admitted to the emergency department with a head injury. On examination, his GCS is 9. A CT scan of brain demonstrated an extradural hemorrhage. Which of the following arteries is most likely source of this? A, anterior cerebral, B, middle cerebral, C, middle meningeal, D, posterior cerebral, H, superficial temporal. So it's C, middle meningeal.
Okay. Extradural hemorrhage in MRCS part A or part B, he want to ask you about the middle meningeal artery, and he want to ask you about the pterion.
Yes.
Okay. Relation, the scenario, young patient has a trauma by a baseball or by any ball or by a stick on the side of the head, and then he started to get the picture of extradural hemorrhage, first drowsy and then loss of conscious after lucid interval. And he will go to ask you about what is the source of bleeding. So it will be middle meningeal. What is this site named? It is the pterion. And what is the structures and the bones sharing to make the pterion, which is a parietal bone. Parietal bone, frontal bone, greater wing sphenoid, and temporal bone. These are the 4 bones making the pterion.
If they mentions the which bone mainly forms the pterion, mainly just one option gives one option, what would be?
I can't get you.
If question comes like only one bone, mention only one bone, which mainly forms the pterion. If they ask for which one is mainly forms the pterion.
No, the pterion is a joint, is a fissure. It is not only one. The pterion is the connection of 4 bones.
Yes.
Okay.
But
the pterion is the connection.
I talked to an examinee from January. He told that there are 2 options there, which one you said 4 from the pterion. He said there was temporal bone also, and other option I can remember, but the 2 options are same, and which one will be? But there were temporal bone, and he answered temporal, and I'm confused. That's why I'm confused.
Yep,
about
two temporal bones.
No, temporal bone and another bone was either is parietal or something like which also forms
this
the
is
pterion.
in September 2020.
No, January. This last exam.
Oh, January 2021.
Okay.
Yes, now I remember. Yeah. They
Okay.
have a question
anyone
on this.
can remember the question?
Yes, related question.
Yeah, it was actually, I think so. The options they were showing is, I think it was 3 bones. What forms the sphenoid? The pterion or the sphenoid bone? Which joins the sphenoid bone, if I'm not mistaken?
Sphenoid bone.
Yes. What forms?
Or the pterion?
What? I think it's written as sphenoid. What forms the sphenoid? From which it has frontal, temporal, and parietal, something like that. There was a few options in there. Yeah, it was not pterion, it was sphenoid.
I think it is not pterion, because pterion he will ask you about the 4 of them, and we have a question in September 2020, but I can't remember exactly. Also asking about the bones here. Also asking about.
So it's the frontal, parietal, temporal.
Yes. Squamous part of temporal bone, greater wing of sphenoid, greater wing of sphenoid, frontal bone, and parietal bone. Parietal. This is the pterion. We will pass all this question. Don't worry. All this question, and even we have a new question in September 2020. All this will discuss, inshallah. Okay.
Squamous part of the temporal bone, and another one is the greater wing of sphenoid.
Greater wing of sphenoid, squamous part of temporal bone.
Okay, got it. All right. Okay, the next one. A 65-year-old man has a history of transient ischemic attacks. He is due to undergo carotid endarterectomy. Which of the following is true of the internal carotid artery? A, begins the level of the 6th cervical vertebrae. B, divides to anterior, medial, and posterior cerebral artery. C, gives off the ophthalmic artery. D, is contained within the skull by preganglionic sympathetic nerves. E, passes through the foramen ovale. So C gives off the ophthalmic artery.
Okay, this is a straightforward question. This is the first branch of the internal carotid artery in the skull, inside the skull. Is there any branches of internal carotid in the neck?
No, zero.
Okay, يعني very common question. How many branches of the internal carotid will in the neck? It will be none.
None, yeah.
No branches. Okay, and the first branch is the ophthalmic artery. The first branch is the ophthalmic artery.
Okay, number 14, a 25-year-old male athlete is in training. At rest, how many liters of blood per minute does his heart pump out? So from the formula, cardiac output equals to stroke volume times heart rate. And from the formula itself is straightforward. We can come out to 5 to 6 liters per minute.
Okay. Whatever it is, any healthy adult, fix it 5 to 6 liter per minute. Any healthy adult, fix it 5 to 6 liters. Whatever, what will it change in an athletic patient or what? The change is in the stroke volume and the rate of the heart. Stroke volume in athletes patient, stroke volume will be increased and the heart rate will be less, but will give us the same cardiac output. Okay?
Okay.
Do you like this question in exam? Many times, by the way. They like it so much. And it is not logic to answer it wrong. That any person can 2-3 liters or 8 to 10 liters. No, 5 to 6 liters is fixed for any adult patient, whatever he is, athletic or not athletic.
If I'm not mistaken, it came out in January 2021. It came out.
This one?
Yeah, the 5 to 6. Yeah, I remember.
Very common, by the way. It is not the first time. Every year, maybe 2 times every year. This question, they like it.
Okay, number 15. A 26-year-old man presents to the emergency department after sustaining a glass cut to his arm. On examination, there is a 10 cm longitudinal laceration on the anterior aspect of his upper arm. He has symptoms suggestive of ulnar nerve injury. On exploring the upper part of the arm, we would expect the ulnar to be medial to the brachial artery.
Okay, we said ulnar medial to brachial artery, and sometimes he asks you, or most commonly he asks you about the median nerve to the brachial artery. It will be lateral, or sometimes he asks you about the full course, which will be lateral, anterior, medial.
Medial.
Sometimes he asks, lateral, anterior, medial. Sometimes he asks you about, the most common question asks you about the full course. Full course, lateral, anterior, medial, LAM. Sometimes he asks you in the cubital fossa. Cubital fossa, it will be medial. This is the median nerve. Last year, he asked what is the relation of the brachial artery to the median nerve?
Lateral.
Which should be lateral. Not to confuse, it should be lateral. The ulnar nerve, always, whatever in the cubital fossa or in the arm, it will be always medial.
Yeah, January 2021 came out. Yeah.
January 21
came out this question too.
Also, you will find many questions here in Fawzia sheet. You will be shocked that many questions in this one.
Correct. Yeah.
Okay. So thank you, Dr. Syed, who's Dr. Munira.
Okay.
Thank you. Right, I'll
Welcome.
continue. A 55-year-old man presents with acute back pain following a severe road traffic accident. A neurological examination reveals a lack of sensation of the umbilicus and below. What is the spinal level of neurological deficit likely to be? Umbilicus is T10.
Okay. The four most common, the three most common areas he asked about this one. And he asked about this one. And he asked about this one. This is the most common 3 areas you like to ask in every exam. What is the dermatome level of the nipple, which will be 4? What is the dermatome level of the umbilicus, which will be 10? And sometimes he tell you a patient going to go to do inguinal hernia under local anesthesia or something like this. What is the dermatome level should be blocked? It will be L1. If you didn't find L1, actually you'll find T12. If you didn't find L1, you'll find T12, but you will never find both of them in the same answer. L1 is the inguinal area, umbilicus, nipple. This is the 3 main question about the dermatomes. Okay.
A 65-year-old man complains of being thirsty and getting up in the middle of the night to get to the toilet. His weight is 95.5 kg, height 1.65, and blood pressure of 167/94. An oral glucose tolerance test was performed and produced the following results. Fasting plasma glucose is 5.9, 2-hour plasma glucose is 11.3. So most likely diagnosis is it's diabetes mellitus.
Diabetes mellitus. Okay. Concentrate with me in this question. Impaired glucose tolerance test. The 2 questions will come. This one. How to diagnose diabetes mellitus in a patient? He in the exam will give you the fasting and the 2-hour post-prandial. The fasting, if it is more than 7.8 and or the 2 hours postprandial more than 11.1, because it came in April 2018. If it is more than any one of them is higher or like this patient is diabetes mellitus. This patient is diabetes mellitus. So here he tell you 5.9, so it's okay. I can't diagnose, so I'll go for the 2 hours. When I went to the 2 hours, I found it 11.3, so this is diabetes mellitus. What is impaired glucose tolerance test? Impaired glucose tolerance test, you will find mostly, he will tell you the fasting will be number like this. Up to 7, no problem. Up to 6.9, no problem. And then he will tell you his postprandial or 2 hours plasma glucose level is 11 or 10.9. This is what we call impaired glucose tolerance test. Impaired glucose tolerance test. Mostly in the exam, he play on this one. This more than 11.3, so it will be diabetes mellitus. If another, he will tell you this 11 is the cut mark of impaired glucose tolerance test. Clear this?
Should I continue?
Yes, okay, continue.
In a 9-year-old child with cellulitis of the hand, which chronological sequence of immunoglobulin production is correct? By cellulitis, IgM precedes IgG. So answer is E.
clear now, screen? Hello? Okay. Hello?
Yes, clear.
Okay. So 9-year-old child, cellulitis is the hint. Chronological sequence of immunological procedure is correct. IgM precedes IgG. This is very important. This is very important. And this is also very important in COVID. Now, you know, some countries ask about this. They don't ask about the PCR for COVID. They are asking about this IgM test. Okay.
Also
They're asking
done
about
for dengue virus for IgM and IgG.
exactly. IgG now they are trying to make IgG for those who had this COVID through the last year to make sure that they had the late immunoglobulin for this infection, so they have this infection. I have some of my relatives was traveling and they refused to have the PCR from him and asked him to do the IgM to make sure if he'd had active stage or he had a late stage of IgG. So always remember that IgM is the early and IgG is the late immunoglobulin that happened after infection. Okay.
All right.
Some questions during our recall, you'll find just it has no other related question and it came once or twice. You have to know like this, and it have no explanation. Just it is something chronological sequence. You have to know IgM precedes IgG and so on. Don't go deep in these questions, please. Just know it. And if it came in the exam, you'll answer it like this. Okay, continue.
Okay. A 60-year-old man presents to the emergency department with epistaxis. The source of bleeding is identified as Little's area and resolves with direct cautery. Which vessel is most likely responsible for the bleeding? A major contribution be sphenopalatine artery.
Sphenopalatine artery. Sphenopalatine artery or Little's or Kesselbach's area. Kessel's area, Kesselbach's area, or sphenopalatine artery. He ask about the artery, sometimes ask about the Little's area, sometimes ask about Kesselbach's area. Okay.
All right.
Continue.
Okay. A 75-year-old man presents with esophageal reflux. Endoscopy confirms the presence of a hiatus hernia. The esophagus passes through the diaphragm, at which level esophagus is T10.
Okay, I think this question we explained last time when we said the first one up is the IVC giving coming from the heart direct on the dome of the diaphragm, so it is at the level of T8, followed by the esophagus in between it and the aorta at the level of T12, as it lies just next to the vertebral column on the posterior, so it is the lowest opening in the diaphragm. So aorta T12, cava T10, and in between is the tube, a tube between two vessels.
Okay. A 78-year-old woman with emphysema is receiving 28% oxygen by mass as the following blood gas results. pH is 7.28, which is low. PCO2 is 8, which is raised, and oxygen is also low. Bicarbonate is increased. Base excess +5. Which of the following is the most likely interpretation? Respiratory acidosis with partially compensated.
Okay, you didn't give me just a comment. How you think about this diagnosis? Okay, The pH is?
pH is low, so it's acidotic. Since
Okay.
PCO2 is also raised, so
it is acidotic, and the bicarb?
it's raised.
Sorry?
The bicarb is also raised.
So it is?
Partially
Alkalotic.
compensated. It's
So it is alkalotic. So it is alkalotic. So I have the pH acidotic and the CO2 acidotic and the bicarb alkalotic. So the pH is related to
CO2.
the CO2. So it is a case of respiratory acidosis. I'm here. So if this is alkalotic, so I have a compensation. It is fully or partial compensation, as
Partial.
it's still not in the normal range, so it is partially compensated respiratory acidosis. Partial respiratory. Okay, it is normal to find bicarb high in a patient with respiratory acidosis.
No.
Okay, so why we find it high and so high like this?
It means that it's a chronic condition.
Chronic condition. This patient has emphysema. This patient has COPD. So this patient for a long time, so he have for a long time, she's 78 years old. It is for a long time, this patient complaining from this sorry, I have some background. So this patient is complaining for a long time from emphysema and COPD. So this patient has a high bicarb compensation. So it is partially compensated respiratory. Questions of acid base or ABG and acid base balance. You have to guess the answer in your mind before reading the questions, before reading the answers. Again, these questions, you have to forget all about this and answer in your mind what you will find here. If you find what is in your mind, it is 99% right. Don't go mix it and then go look again, partially look again, then look again. No, in your mind, this is a case of partial compensated respiratory, and then I go here, I found it, so I'm completely right. I am completely right, okay?
Okay.
Yeah, this came out in January 2021 also.
January 2021?
2021, yes, this came out exactly. With the same order.
Really? I know, you will find many, by the way.
A 26-year-old man is having a stereotactic frame fitted to his skull prior to radiosurgery on a cerebral arteriovenous malformation. 4 pins secure the frame tightly through the scalp to the outer table of the skull, 2 anteriorly and 2 posteriorly. On incision of one of the posterior pins, arterial hemorrhage is encountered. Which artery is most likely to have been punctured? A. Ascending pharyngeal, B. Middle meningeal, C. Occipital, D. Posterior cerebral, and E is posterior communicating artery. Occipital artery is the only logical answer.
Okay. Sorry, I couldn't get you.
It's occipital artery.
Occipital artery. You know this, the pen used for radiotherapy for patient stereotactic frame. Okay, they are put with 4 pins here around the skull to start to give a stereotactic therapy or radiotherapy or many neurosurgery intervention, and they make it like this around the skull. Okay, like this. And then they have pins to fix it like sometimes you do into external fixation in the lower limbs, the pins through the skin to the skull, and so common that they can injure the occipital artery. Very common to injury posteriorly the occipital artery. Next question.
A 26-year-old man presents with a 2-month history of unilateral testicular swelling, and ultrasound shows a heterogeneous mass within the testes with surrounding fluid. His blood test shows an elevated alpha-fetoprotein. Which of the following is most likely diagnosis? Based on age alone, is teratoma likely?
Okay, twin teens, heterogeneous mass, elevated alpha-fetoprotein, so it is teratoma. Teratoma. You know this question, we explained it many times, yeah?
أو الدراما ما شو زدان.
Sorry?
What? Silver.
Okay. Yeah, next
continue?
question.
Okay.
Continue till 30.
Alright, a 2-day-old baby presents with increasing respiratory distress. He was born at term by normal vaginal delivery. On examination, he has cyanosis of the lower limbs and marked respiratory indrawing of the chest. His femoral pulses are absent bilaterally, and he has been anuric for the last 2 hours. Pulse rate is 140 beats per minute. Regular, his blood pressure is 60/30 in both upper limbs. What is the most likely diagnosis? A. Hypoplastic left heart syndrome. B. Interrupted aortic arch. C. Pulmonary atresia and VSD. And D. Transposition of the great arteries and E. Tricuspid atresia. The answer is interrupted aortic arch.
Yes, exactly. This interrupted case, he is absent femoral pulse and has been anuric, so there is no blood supply reaching down to the lower half of the body, and he has his pulse rate tachycardia and has blood pressure 60/30 in the upper limb. So he have blood pressure in the upper limb, but he has absent pulses in the lower limb, and this happened with the interrupted aortic arch or coarctation of the aorta, like this picture. And there is many types, just don't care about the types, but this is the types of coarctation or interrupted aortic arch. Okay.
Okay. A 50-year-old woman presents with a history of right upper quadrant pain and jaundice. She reports that her urine was dark in color and that her stools are offensive and difficult to flush. Which of the following explains the dark urine? Is increase in conjugated bilirubinuria.
Okay, so we said before, dark urine, conjugated bilirubinemia or conjugated bilirubin. If it is normal, if it is in stool, it will give dark color of the stool. If it is absent, it is pathologically absent, so it will give pale stool. In urine, if it is normally absent, so the urine just will be amber yellow, but if it is in high amount in urine due to conjugated bilirubin, it will give the urine dark color. So this is the dark color of the urine is due to increase in the conjugated bilirubinemia.
Actually, in January 2021, there was a similar scenario regarding this. But what they did was they changed the question to, instead of urine was dark in color, they said that what is responsible for the patient's pale stools?
Absence of conjugated bilirubin.
Yeah, absence.
Okay. So many questions January 2020 till now, yeah?
Yes, the occipital artery also came out January 2021.
Okay, next question.
An 80-year-old woman who has suffered a fall is found lying on the floor where she has been over for 12 hours. Initial assessment shows that she has a core temperature of 28 degrees. What would the expected early physiological response to her temperature be? A. Increased fat metabolism. B. Increased constriction of peripheral blood vessels. C. Increased hypothalamic set point. D. D, increased metabolic rate, and E, increased thyroid activity. Hypothermia, first response is vasoconstriction of the peripheral blood vessels. So it's B.
Okay, yeah, this is the first response in patient with hypothermia is the decrease in the increased constriction of the peripheral blood vessel to decrease the blood flow in the unimportant organs, and at the same time decrease the loss of temperature from blood through the skin. So it will be vasoconstriction to drive the blood to the internal organs to be more warm and to preserve temperature. Okay.
A 12-year-old boy presents to the emergency department 2 hours after helping his father cut the grass. He complains of rhinorrhea, itchy eyes, sneezing, and a blocked nose. He is apyrexia with a hemoglobin of 12.2, total white count of 6.8, with raised eosinophil count. Chest X-ray is clear, which immunoglobulin is likely to cause this reaction. Atopy is IgE.
Okay, it is atopy. Hypersensitivity reaction type 1, as we agreed before, acid. Ig-T is our mnemonic for the hypersensitivity reaction. Acid, which is anaphylactic, cytotoxic, immune complex, and delayed hypersensitivity reaction. And Ig-T is E and GG, and then T cell hypersensitivity reaction. Okay.
A 45-year-old man presents with backache and leg pain due to prolapsed lumbar intervertebral disc. The pain, which is aggravated by coughing and sneezing, radiates to the dorsum of the foot. On examination, there is weakness of the dorsiflexion of the foot, which nerve root is likely to be involved. Dorsiflexion of the foot will be L5.
Dorsiflexion is a foot. Dorsiflexion is a foot is
L5.
L4. Okay.
L5 is the toe.
Okay, if I didn't find, in the exam I didn't find, what I'll go for?
The next one is
L5.
L5.
L5. Okay, it is mainly L4, L5, but mainly L4. It is L4, L5, but mainly L4. And the big 2 is L5. But if I didn't find in the exam like this question, go for L5. Not to go for L3. Not to go for L3. Okay. L3 is mainly for the quadriceps for knee extension. But the ankle dorsiflexion and the big 2 extension, both of them are L4, L5. Okay.
Okay. Okay. A 75-year-old woman who has a carcinoma of the upper rectum undergoes anterior resection. The arterial blood supply of the upper rectum arises from which of the following? It's A, celiac, B, ileocholic, C, inferior mesenteric, D, internal iliac, and E, superior mesenteric. Superior rectal is from inferior mesenteric artery.
Okay, inferior mesenteric artery give us the rectum, sigmoid, and the left colic up to the splenic flexion. All this by the inferior mesenteric artery.
Okay. A 65-year-old man is undergoing an abdominal aortogram. A stenosis is demonstrated in a lateral aortic branch arising at the level of the body of the second lumbar vertebra. The stenosed vessel is likely to be L2 is second left lumbar artery.
Okay, this is the level of the second lumbar vertebra. Okay, abdominal stenosis inserted in the left aorta, starting at the level of the body of the second lumbar vertebra.
lumbar arteries corresponds with the vertebral level.
Exactly. Many try to say this is the left renal artery.
Renal artery is L1.
L1.
Exactly. Renal arteries are L1. Renal arteries are L1 at the transpyloric plane. Okay. Second lumbar arteries are the level of second vertebra. Okay.
Yeah. Should I continue or?
Thank you. You finished 30. So who's next? Dr. Hadiza? Yeah. Ready?
Yes, I'm ready.
Thank you, Dr. Munira.
Question 31. A 40-year-old man is admitted to the surgical day case unit for repair of his left inguinal hernia. On examination, he is noted to have diffuse skin tanning, spot pigmentation of the elbows, nipple, and buttocks, and pigmentation of the scar from a previous right inguinal hernia repair. 3 hours after the operation, becomes severely hypotensive. What is the most likely cause? This says adrenal insufficiency, but I don't know the mechanism.
You don't know the mechanism of adrenal insufficiency?
How
Okay,
adrenal
okay,
insufficiency.
okay. 40-year-old man is admitted to the surgical day case to repair of left inguinal. On examination, he is noted to have diffuse skin tanning, spotty pigmentation of the elbows, nipples, and buttock. This is a picture of Addison disease. This is a picture. Mainly, he will tell you pigmentation on the trunk and buttocks. The patient has diffuse skin tanning. The patient has dark skin in different areas of his body, especially in the armpits, between the sides, and in the lower abdomen, and on the flanks. And this patient also had spotty pigmentation on the trunk and buttocks. This is a picture of Addison disease, which is adrenal insufficiency. Pigmentation of the scar of previous right inguinal hernia repair. 3 hours after operation, he becomes severely hypotensive. What is the most likely? This patient didn't take his cortisol or hydrocortisone dose, supportive dose for any procedure he will go. He have to take any supportive dose for corticosteroid. Okay, picture of pigmentation, especially he will tell you pigmentation of the buttock. Sometimes he tell you Addison disease, sometimes tell you adrenal insufficiency. Okay.
Why is hypotensive? And if you explain it again.
This patient gets an Addisonian crisis.
Addisonian crisis.
Yes, Addisonian crisis. He will go hypotensive. This patient has sudden and acute adrenal insufficiency and cortisol insufficiency. Okay.
Okay. Okay. Can I go to the next question?
Read about the Addison crisis. Okay. I just don't go to details because if you went, no. This is just Addison disease. If you want more details in endocrine, it is very complicated, really. I'm wanting to make it simple. In the exam, you'll find the question like Dr. Said said. You'll find the question like this.
For so that I can, if the question is in the exam, I know why I'm answering this.
Okay. Next question.
Should I read the Addison's disease?
No. Okay, read it.
Okay. Adrenal glands not produce sufficient. The screen is gone. Okay. Adrenal glands not produce sufficient steroid hormones. and skin will be hyperpigmentation, low blood pressure, weakness, weight loss. GIT problem will be nausea, diarrhea, vomiting, constipation, abdominal pain. Skin will be vitiligo. Adrenal crisis includes fever, syncope, convulsion, hypoglycemia, hyponatremia, severe vomiting, and diarrhea.
Okay, thank you.
32. Okay. 19-year-old woman presents to the emergency department with profoundly hypovolemic, having fallen from a horse. Posterior anterior chest radiograph shows fracture to the medial third of the left clavicle. Medial third of left clavicle. Which of the following vessels was most likely damaged? Medial third of left clavicle related to the subclavian artery. Left side, left subclavian artery. And the picture we can see in the picture
Which is
in the medial third.
said
there
he's
is
a,
left subclavian.
yes, exactly. This present says, yani this patient profound hypovolemic radiographic shows fracture to the medial third of the left clavicle, which of the following? By the way, you can be confused. You can be confused between the subclavian artery and I think in some scenarios in MRCS he told you in subclavian vein. But here is the patient. Here is the patient is profoundly hypovolemic. This is an arterial bleeding suddenly happen. So can direct your mind to the artery more than the vein. So here is the subclavian artery is the source of bleeding.
Someone asked me this why there is artery, why not vein, and I could answer. Now I know why.
Yes, and there is no vein. Sometimes he wants to confuse you. Okay, he doesn't bring the vein at all.
The next question, number 33. A 65-year-old man presents with an inguinoscrotal swelling in the right groin, which is non-tender. Cuff impulse is elicited. At operation, an indirect inguinal hernia is repaired. The cremasteric muscle is derived from which of the following? The question is, cremasteric muscle derives from which muscle? It's internal oblique muscle. Cremasteric arises from internal oblique muscle.
Okay.
Internal oblique muscle gives of both the cremasteric muscle and fascia.
Okay.
Which is one of the covering of a
this is the
cord.
most common. This is the most common question in the exam. Okay. Cremasteric muscle. Can you read this, please?
Okay. Layers of a scrotum or only the covering? The layers of a scrotum
read both of them.
The layers of a scrotum are from superficial to deep is skin, dartos muscle,
What is the
external
dartos muscle? What is it? What is the dartos muscle?
Scrotum.
Subcutaneous.
Subcutaneous, yes.
And subcutaneous tissue, because he asked about this one. Okay, continue.
Okay. Skin, then dartos muscle, external spermatic fascia, cremasteric fascia, internal spermatic fascia, peritoneum, and tunica vaginalis. This is the layer of a scrotum. And spermatic cord coverings are 3 layers of fascia derived from layer of anterior abdominal wall. External spermatic fascia derived from external oblique muscle. Cremasteric fascia. Yes, cremasteric fascia derived from internal oblique muscle. Internal spermatic fascia derived from fascia transversalis and attached to margin of deep inguinal ring.
Okay. The most common question in the exam. Cremasteric fascia derived from internal oblique. External spermatic fascia from external oblique. And the last one is the tunica vaginalis is derived from
peritoneum.
Peritoneum. Very common in the exam. Mainly because we have it about 5 to 6 times in our recalls. Tunica vaginalis is derived from peritoneum. Don't forget this. Okay.
Is the since the develop development of testis. The relation is starting from the development, I think.
Yes, exactly. Yeah, he want to ask about this. Chromostatic, internal oblique, external. Spermatic fascia is the most easy from the external oblique, and then ask about internal, the tunica vaginalis from the peritoneum.
Number 34, a 70-year-old woman is in the recovery area and receives 28% oxygen by mask. Blood gas shows pH 7.1, which is acidic, low pH. If it was 7.4 is neutral, less than 7.4 is acidic.
Okay.
Carbon dioxide 10 kilopascal, it's acidosis due to. And oxygen 12 kilopascal, I think is normal. Respiratory inhibition. Okay. And the reduced sensitivity of which receptor is most likely to be responsible for this blood gas? It's central chemoreceptor. Central chemoreceptor sensitivity is reduced, hence there is respiratory inhibition and respiratory acidosis.
Okay, central chemoreceptor is very sensitive. CO2, increase in CO2 and decrease in the pH of the patient. It's very sensitive to respiratory acidosis. Central chemoreceptors are very sensitive to respiratory acidosis. In respiratory acidosis, there is pH is low and CO2 is high. Okay. Peripheral chemoreceptors, you can add sensitivity to O2. You can add, but you don't have any question, just for your mind. But we have many questions about the central chemoreceptor, and they are sensitive to change in the pH of the blood plus the CO2 of the blood.
Okay.
Continue.
COPD patient have peripheral chemoreceptor. Someone wrote something.
Okay. Really out of scope of our study. We don't have any question about it. It will just be confused. Good to have new information, but in the last revision, the last few weeks before the exam, concentrate about all the questions and the answer. If you want to have every question of this, I can give you many informations, but really out of scope, and it will make you more confused. Thank you, Dr. Vijay.
We can't remember everything.
More information in your study in part A is catastrophe. Yes. Catastrophe. It will give negative effect on your study and on your acceptance and on your exam. Okay.
Number 35, a 28-year-old man presents with pain in his left scrotum. Diagnosis of varicocele is made. Which vessel involved? Varicocele is due to testicular veins. Okay. And there is another relevant thing, I think, with the kidney tumor and varicocele.
Okay, this pain in the left scrotum, diagnosis of varicocele. Here is an anatomy question. He asked about which vessel is involved. Varicocele or pampiniform plexus of veins and the scrotum are draining on the left, on the testicular veins or in the gonadal veins. Another question very famous in the exam is, where does the right or left testicular vein drain? Very common.
Testicular vein, left testicular vein drain into the left renal artery, and right testicular vein drain into directly the vena cava.
IVC. The IVC.
Okay, that's why the left testicular vein has a high pressure than the right testicular vein, and that's why we almost always more than 90% find in normal persons with no tumor with normal renal veins, we find varicose veins on the left side of this patient. In our practice, we never said we never saw a patient with right varicose vein. We always see left varicose vein or bilateral. Left or bilateral. We don't see just right. And many theories say that the right side became dilated by connections from the left side. Okay? Hello?
Can we go to the next?
Yeah, okay.
Okay. Next question.
Number 36. A 60-year-old man who is a heavy smoker presents with a 10-day history of frank painless hematuria. His prostate is slightly enlarged on rectal examination. His hemoglobin is 11.3 gram per del, normal. Creatinine 84 picomole per liter. Prostate specific antigen is 3.1 or it's 3.1 maybe 3.1 milligram per. What is the most likely pathological process? This is frank painless hematuria is due to carcinoma, mostly in the bladder, painless hematuria carcinoma.
Okay.
And this is benign prostate hyperplasia, no. Or prostate cancer is prostate specific antigen 3.1. Is it normal?
Yes.
Normal. And then no prostate cancer. Renal carcinoma. What to see for renal cell carcinoma?
Okay.
Okay, the transitional cell carcinoma of bladder. The answer is
Heavy
transitional
smoker.
cell carcinoma
Okay.
of bladder.
Okay, we have a patient with frank painless hematuria. So I can say this is cancer bladder, or it can be renal cell carcinoma. Okay, in renal cell carcinoma, what he said here, his prostate is slightly enlarged, normal, and rectal examination, his hemoglobin is this, and this. He gave any picture of renal cell carcinoma?
No, not at all.
Okay, renal cell carcinoma has a specific clinical picture, which is right loin fullness, pain. No, I'm talking about. I'm talking about a clinical picture. I'm not talking about paraneoplastic syndrome. Patient with renal cell carcinoma has triad of pain, mass, hematuria. Pain, mass, hematuria. Loin pain, loin mass, and frank hematuria. Okay. I don't have all these, so I will not invent or I not imagine a scenario in my mind. Okay, let's go. What can make frank hematuria also? Transitional cell carcinoma of the bladder. Transitional cell carcinoma of the bladder. Okay, if I have in this scenario a squamous cell carcinoma of the bladder, I can have it easy. Cell carcinoma of the bladder. I can have easily squamous cell carcinoma. Can I go for this choice?
No.
Exactly, no, because if you want to confuse you, this patient is a heavy smoker. Always keep in your mind in cancer bladder, you have two important types. Actually three, but keep the third one. First one is the main, which is transitional cell carcinoma. Risk factors, smoking, and dies. Okay, smoking and dies. As patient has a cancer bladder and has a history of smoking or working in aniline or any vinyl plastic, exactly, any factory or any occupational
factory, PVC
yes, ABC factory, something like this, any plastic factory or this factory. So this is occupational cancers related to transitional cell carcinoma, to what he working or what he is smoking. Okay. If you want you to choose squamous cell carcinoma of the bladder, you have patient with chronic bladder
stones. Yeah.
stones, or patient bilharziasis. Patient has a very history of hypertension. And the third one is indwelling or repeated castration.
Yeah.
These three direct your brain to squamous cell carcinoma. Squamous cell carcinoma. By the way, I'm talking every word I'm telling you here is an exam question. Okay, I'm not just explaining for fun. So smoking or any factor with dye, so this patient transitional. History of bilharziasis or urinary bladder stones for long time, or repeated castration or long time castration. Patient stay for long time castration due to BPH. This patient will have squamous cell carcinoma.
In
the last
SCC, they have some specific. They mention some specific area or country or ethnicity.
Forget about, keep these words as in your. Sometimes they ask bilharziasis about Egypt or from Africa. Okay, that's only about bilharziasis. Say said from Egypt or from Africa or from rural area and something like this. The last thing, maybe it never.
Sir, what's the third point for the squamous cell carcinoma? First was the urinary stones. Second is what is the second one? Third is the
bilharziasis and indwelling caster.
Okay.
Okay. The last very rare tumor is adenocarcinoma. And this is above urachal malformation. Above urachal remnants. Patient in infant has bladder extrophy. Patient has urachal fistula in childhood and repaired, and the patient still have some urachal mucosa in the bladder. This patient has adenocarcinoma, and this is very bad. I can't. This is, I think, less than 5%. Less than 5% of all bladder cancer, and it on top of urachal malformation. Clear? Forget about. Keep this. Yeah, continue.
So carcinoma bladder is TCC, SCC, and adenocarcinoma.
Adenocarcinoma is very rare, and I think I saw it only one time during my study, and one recall maybe before 2017. Okay, but forget about it now. Keep in transition cell carcinoma and squamous cell carcinoma.
Okay. The next is 37.
Okay.
37. 34-year-old woman presents with an irregular mass in the right breast, which is clinically, radiologically, and histologically malignant. Her mother died of breast cancer at the age of 58, and her grandmother died of ovarian cancer at the age of 55. Which gene is most likely to be involved in the development of this woman tumor? This is BRCA.
BRCA1 and BRCA2. BRCA1 and BRCA2 are the main gene responsible for hereditary breast cancer. Hereditary breast cancer. Okay. This is again risk factors for breast cancer. Low risk factor, moderate risk factor, and high risk. And this is age of first birth. It will be after 30, mainly 35, and in the exam will give you 40. So this is one of the risk factors: early menarche, late menopause, nulliparity, obesity, and hormone replacement therapy as well. High risk is BRCA1 and BRCA2 mutation. and the age طبعا.
Number 38.
Okay.
Number 38, 65-year-old man presents with a non-tender swelling in the right hemiscrotum at operation. The hydrocele sac is opened and 400 ml fluid drained. Which anatomical structure surround the fluid? The tunica vaginalis. In hydrocele, the fluid accumulation is in layer of tunica vaginalis. So the indirect question, it says the layer is tunica vaginalis.
Okay. Tunica vaginalis from which derived from?
Tunica vaginalis from peritoneum.
Peritoneum. Okay, exactly. Next question.
39. Number 39. 24 years old man is brought to the emergency department following a road traffic accident. He has obvious airway compromise due to mouth or fecal hemorrhage, which requires a surgical airway. The surface landmarks used to localize the optimal site for a tracheostomy incision are midway between the suprasternal notch and which of the following? Suprasternal notch is the manubrial notch in between two clavicle. This is suprasternal notch, and cricoid. Cricoid and suprasternal notch in between, they give incision for tracheostomy.
Okay.
Yeah.
Site for tracheostomy, anatomically, you'll put 3 fingers, 1 finger on the suprasternal notch and 1 finger on the cricoid cartilage, and then you put the middle finger and the third finger, which is the middle finger, you put it in between, and this is site for tracheostomy. Suprasternal notch and cricoid cartilage. Next, please.
Okay. Number 40. Number 40. A 60-year-old man has an anterior resection for a high rectal carcinoma. The histopathology report indicates the lesion is Duke's stage B. What is the approximate average 5-year survival rate for patients with this lesion? Duke's stage B is 70% survival rate. 5-year survival rate is 70% for Duke B.
Exactly. The most important 3 you will be asked about: Dukes A, Dukes B, and Dukes D. Okay. Dukes A, he will give you 90 or 95%, very good prognosis. Dukes D, it is 5% or less, 5% or less, and Dukes B is 70. In the exam, he will give you 70%. Okay. In exam, he will not give you 80 because he knows that Dukes A is 90. This is Dukes A, 90. So he will not give you a very close percentage. He will give you 70. So this is Dukes B, and 5% is Dukes D.
Okay. 20 years man present to the emergency department after accidentally tripping over and laceration his hand on a glass bottle. On examination, there is a 2 centimeter laceration on the hypothenar eminence with loss of flexion in the distal interphalangeal joint of the little finger. What is the most likely tendon to be injured? This is flexor digitorum profundus because the distal interphalangeal joint, flexor digitorum profundus attached to the distal interphalangeal joint.
Exactly, very common by the way, this question in the exam.
So
Injury to the
tendon.
distal phalanx. Distal phalanx is movement is responsibility for flexor digitorum profundus, which is attached to the base of the distal phalanx, and its rupture.
This tendon is mostly repaired in the casualty and emergencies. Mostly this tendon we find like cut injury or anything.
Yes, exactly. Okay, next question.
Okay. Number 42, a 75-year-old man who smokes heavily underwent coronary artery bypass grafting 6 months back. A left internal mammary artery graft was used. He now complains of angina on pegging his laundry on the washing line to dry. Which of the following lesion explain these symptoms? The pegging in his laundry washing line to dry, because while doing this he has to raise his hand. Then stenosis of the subclavian artery proximal to the first branch. This is answer is E. Proximal to the first branch means vertebral artery, maybe, but the first branch is vertebral artery. And near the vertebral artery, if there is a stenosis, there will be less blood draw, and the blood will drawn from the circle of Willis to compensate, and you will feel dizzy, like something.
The patient, yeah, the patient will be dizzy. Okay, so this patient is heavily smoker, so this patient has chronic heart disease, the patient has Berger disease, and has many complications. Left internal mammary artery graft is used. And this is how the left internal mammary graft can be used from the subclavian artery. Okay, and then the patient, he complains of angina on taking his laundry on washing line to dry or something like this. Patient tried to make an arm exercise or arm effort, and he tried to increase the blood supply during his exercise. So there is the stenosis proximal to the vertebral artery, which is the first branch, and the patient can increase his blood supply, so will withdraw blood and reverse the blood flow through the vertebral artery to supply the arm. That's why the patient always feel dizzy and feels angina pain when he using his arms. Okay, because there will be less blood supply coming, less blood supply from the left internal or the internal mammary, and the vertebral artery will go through the subclavian artery. So this patient will have less blood supply going to the heart. Clear?
Okay.
Okay. And this is a very nice picture. I think you'll never see it again. Blood will come from here to here. Mainly try to dilation of this for the arm exercise, and also the blood trying to supply this vessel. Next question.
43. A 50-year-old alcoholic man presents to the emergency department and is found to be unable to extend his wrist, thumb, and finger of his right hand. He is also found to have weak extension of the right elbow joint and loss of sensation of the dorsum of first Weber's.
What is this manifestation? Manifestation of which nerve?
Dorsum of
Radial nerve.
Thumb, wrist, and finger extension. You have all of this. Loss of extension.
Extension loss is
extension
related to
of the
radial
hand.
Extension.
Okay, and sensation, loss of sensation. And the first web
dorsum of
space.
first web space means radial side.
Okay, so what is the most likely?
Radial nerve injured.
Okay. So this is what's called Saturday syndrome, or sometimes Saturday night or crutch syndrome.
I didn't listen clearly.
Sorry?
What syndrome?
Common radial nerve in alcoholic man over Saturday. It's called Saturday night or crutch syndrome.
Saturday night. Okay.
Saturday night or
Saturday
crutch
night
syndrome. Saturday night palsy. Okay. This is because compression on the radial nerve of the axilla during loss of conscious or patient alcoholic and drunk and so on. Our famous question.
Oh, it's very 44 number. A 55-year-old man presents with acute back pain following a severe road traffic accident. Neurological examination reveals lack of dorsiflexion of left ankle joint. Which of the following is spinal cord?
Dorsiflexion of the ankle is root.
L5.
Dorsiflexion
Sorry,
of the ankle
L4.
is
L4,
Ankle
L5.
dorsiflexion L4.
L4, L5. Okay, L4.
L4. Yeah, L4.
Okay, which of the spinal cord segment most likely to be injured?
Which of the?
Okay, continue. Hello?
Yes.
Continue.
Okay. The dorsiflexion of left ankle joint is like which of the following spinal cord segment are most likely to be injured? Okay. This is L4, 5, S1 because another option there is no L4. One is L4, L2, L3, L4, but this will be wrong because there is no involvement of L3 here.
Okay, why is this not? There is L4 here.
L4 here, but for L3 there will be knee joint.
Yes, we have no problem with L2, L2 side flexion, L3 leg extension.
Yes.
And we don't have any problem about this, anything mentioned in the, but L4, 5, S1 can give us the dorsiflexion of the joint. Okay, most important that L4. If you need to add any nerve root, you have to eat L5, not L3. Okay.
Okay.
Last question, please.
Okay, 45.
Yes.
21-year-old man is admitted to the emergency department with stab injury to his right chest. Pulse rate is 110 beats per minute. Blood pressure is 85/40. Chest X-ray shows large right hemothorax and very small right apical pneumothorax. Chest X-ray hemothorax plus pneumothorax. Which is the first substance secreted in the process leading to increased renal absorption of sodium in response to above injury? It says the renin-angiotensin mechanism. The first substance secreted is renin.
Okay, this is the first. Don't be
hypovolemia.
confused between the first response and the first substance. Okay, and hypovolemia or hemorrhage, the first response is?
First responses are RAA. Sorry, response. First response is baroreceptor. Baroreceptor.
Then the renin-angiotensin, but the first substance released is?
Renin.
And another question came twice last year. And what is the substrate for renin?
Angiotensinogen.
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 What's the substrate for renin? The question came like this: what is the substrate for renin? It is angiotensinogen. Angiotensinogen. Okay, thank you, Dr. Where you mute yourself. Thank you, Dr. Khadija. Thank you, Dr. Khadija. Okay, thank you, Dr. Munira. I think you raised your hand. Dr. Amina, sorry. Dr. Amina, you raised your hand, yes? Are you ready?
Yes, I'm ready.
Okay, go for the next 15 questions, please.
A 21-year-old man has been stabbed in the back of the knee, dividing the popliteal artery, and is undergoing repair via a posterior approach. Which of the following structures is most likely to be encountered first when dissecting deep from the skin incision? So the first structure is the tibial nerve.
Tibial nerve. Okay, as we know, this is the order of structures on when approaching the knee posteriorly. Tibial nerve, then the vein, then the artery. Tibial nerves and the veins and the artery. So you have two important questions in this point. If he tell you where is what is the most common structure injured when you're approaching the knee, approaching knee surgery from posterior or from the popliteal fossa, which is the tibial nerve.
Oh, sorry.
Tibial nerve.
From the posterior
tibial
approach.
nerve. From posterior approach. If you have
yes, sorry, yeah, tibial nerve.
Knee dislocation. If you have knee dislocation, you have knee dislocation or knee injury, what is the most common structure can be injured?
Popliteal artery.
Popliteal artery. Why exactly popliteal artery? Because popliteal artery in this area is a little bit fixed to the posterior capsule of the knee joint. That's a very crucial thing, because popliteal artery aneurysm are very common because of this, because it is a fixed place of the artery. Always has traction during movement of the knee. And the other thing is any injury to the knee joint, the first thing you have to do to check the distal pulsation, because popliteal artery are very common to be injured during knee dislocation. Clear? So this is the order of the structure. The nerve from behind, then the vein, then the artery. Attach it to the posterior capsule of the knee.
Sir, can
78-year-old woman presents.
Okay, continue.
Okay, 78-year-old woman presents with urinary urgency and incontinence. The external urethral sphincter is innervated by which of the following nerve roots? So it's by the pudendal nerve, which is S2, 3, and 4.
Okay, pudendal nerve S2, 3, 4 supplies the external urethral sphincter and the external anal sphincter as well.
Sphincter. Mm.
Okay.
A 40-year-old woman presents with a parotid tumor. A biopsy reveals perineural invasion, which is the most likely pathology. We said this in the first sheet. Adenoid cystic carcinoma is the most common malignancy that would have perineural invasion.
Okay, what is the most common benign tumor?
Pleomorphic adenoma.
Pleomorphic adenoma is the most common.
Pleomorphic adenoma is the most common benign tumor. What is the most malignant? Most common malignant?
Mucoepidermoid carcinoma.
Mucoepidermoid carcinoma. What is the most common malignant with perineural invasion?
Adenoid cystic carcinoma.
Adenoid cystic. Very common question. These three are very common questions in the exam. Mucoepidermoid, most common malignant tumor. If he mentioned any perineural invasion, you have to go for adenoid cystic. Adenoid cystic carcinoma. Okay. Next question, please.
Oh, wait, I can't see the question.
Yes.
Okay. 19-year-old man was assaulted and sustained injuries to the right side of his head. After 2 weeks, he noticed dilation in his right. He noticed his right eye is dry and it could not produce tears. From which ganglion is the postsynaptic fibers arise to supply the lacrimal glands? The geniculate ganglion, inferior ganglion of the vagus nerve, otic ganglion, pterygopalatine ganglion, superior cervical ganglion. It is the pterygopalatine ganglion.
Pterygopalatine ganglion gives here, as you see here, in the parasympathetic cranial nerve ganglion. Ciliary ganglia go to the eye. Pterygopalatine, which is the most important and most common in the exam. The most important parasympathetic ganglia, cranial parasympathetic ganglia, is the pterygopalatine ganglion. Okay, it goes to the lacrimal gland and responsible for the lacrimation. It also goes to the palate and nose. The other one is submandibular gland, and this goes to the submandibular gland and submandibular ganglia to submandibular gland and sublingual gland, and the otic ganglia, which go to the mucous membrane and the parotid gland. To the parotid gland, which is most important. Okay.
Okay. A 35-year-old man undergoes a right inguinal hernia repair under general anesthesia as a day patient. He has a nerve block after the procedure. On recovery, he has weakness of the right leg. Which nerve has been affected? This is the femoral nerve.
Femoral nerve. So during inguinal hernia repair, under anesthesia, the nerve block reduce recovery weakness of right leg extension. Sometimes he tell you right leg extension, and this will be femoral nerve. Femoral nerve injury.
If it's a muscular weakness, then we'd go for femoral nerve. If it was a sensation, then we'd go for ilioinguinal nerve.
Exactly. Nerve injury, yes, nerve injury, and the patient has anesthesia or paresthesia at the inguinal area and the upper scrotum. This will be the ilioinguinal nerve. If he has weakness of the leg or sometimes extension of the leg, so it will be the femoral nerve, which supplies the quadriceps muscle responsible for knee extension.
Sir, could you please, sorry.
Go on.
Yeah, okay.
Sir, could you please repeat the sensation? One question means if there is loss of sensation, then it's the ilioinguinal nerve, right?
Okay, during inguinal hernia repair.
Okay.
Inguinal hernia repair. If there is a sensory problem, it will be the ilioinguinal. If there is a motor problem, by the way, this is very rare because this is very far, but maybe complicated hernia, motor problem, and he will tell you weakness of the leg, or sometimes weakness of leg extension. This is supplied by femoral nerve to quadriceps muscle responsible for knee extension. Okay.
Thank you so much, sir.
There you go. Okay.
A man suffers a brachial plexus injury. On examination, he has Horner syndrome in association with upper limb paralysis. Which nerve roots does the Horner syndrome suggest involvement of? So Horner syndrome is in the stellate ganglion, which is in T1. So we'd go for D, C8, and T1.
Exactly. What is the nerve of the ganglia?
T1.
No, the ganglia responsible for the Horner syndrome.
The name, the stellate ganglion.
Stellate ganglia. Okay. Stellate ganglia. Very common when you are going to do dorsal sympathectomy. They always abolish T3 and T2 and they preserve T1 because when if they ablate T1, mostly stellate ganglia is injured or has from the current or something like this, and the patient will be presented by Horner syndrome. Okay, this is dorsal sympathectomy. Okay, you preserve T1 because you scare from or afraid from Horner syndrome. or are muted? You can hear me?
Yeah, we can hear you.
Yes.
Okay.
Yes, we can hear.
Dorsal sympathetic. يعني for your mind to know this good يعني it's just out of our scope, but it's very funny to know it during lumbar sympathectomy. Lumbar sympathectomy. They are ablating lumbar sympathectomy. Sometimes they do it for spastic conditions, like patient has Raynaud syndrome or increased the sympathetic tone in the lower limbs. Okay, to decrease the sympathetic tone in the lower limb, they are ablating L2 and L3. And they preserve here is ablating T2 and T3. And they preserve T1 here is ablating L2 and L3. And they preserve L1 because if the injury to L1 will make
loss of ejaculation reflex.
Yeah, loss of ejaculation. Okay, so injury of L1. So you can remember this. I can't ablate T1 because of Horner syndrome. I can't ablate L1 because of loss of ejaculation. Okay, just to remember it.
Okay.
Okay. Next question.
A 60-year-old woman with breast carcinoma complains of difficulty chewing her food and is found to have numbness of the lower lip on one side. CT scanning shows a metastatic lesion affecting the bony skull base on the same side as the lip numbness. Which foramen is the most likely to involve? So the difficulty chewing of the food, this is it is innervated by the mandibular branch of the trigeminal. And
Yes.
it is in the foramen ovale.
Okay, this indirect question about the mandibular nerve. You want you to know this mastication and numbness is from the mental nerve and from the branches of the mandibular branch or mandibular division of the trigeminal nerve, and the mandibular division pass through the foramen ovale. Mandibular pass through the foramen ovale. Very important to know. Okay, and the ophthalmic division pass through
superior orbital fissure.
And the maxillary division
From foramen rotundum.
I know some.
Sorry, rotundum. Yeah.
Okay.
Foramen rotundum.
Oh,
yes.
very important. This say yes here. V1 ophthalmic from superior orbital fissure, V2 foramen ovale, V2 rotundum, and V3 from the foramen ovale. This is anatomic question, purely.
Which one of the following muscles is an extensor of the hip? The semitendinosus. It's only posterior.
Okay. Extensor of the hip. What is the main extensor of the hip?
The gluteus maximus.
Gluteus maximus. Assisted by the semitendinosus and semimembranosus and so on. But the my main extensor is the gluteus maximus. Okay, main abductor of the hip.
Abductor.
The gluteus medius and minimus.
Minimus, yeah.
Gluteus medius.
Yeah,
helped
medius.
by the minimus. Yeah. Nerve supply.
The superior gluteal.
Superior gluteal nerve. Yeah. Superior gluteal nerve.
Injury to the superior gluteal. What will happen? Trendelenburg gate. Very important. Very important. Trendelenburg gate. Superior gluteal nerve. Gluteus medius. Very, very important. Because many question about hip dislocation or fracture neck femur, and then through a posterior approach, and after the operation the patient has a Trendelenburg gate, or the patient has a dropped pelvis on the site of the operation. So this is because of paralysis or injury of superior gluteal nerve.
In order to expose the right axillary artery, a transverse skin incision is typically made below the clavicle from a point just lateral to the sternal end of the clavicle to the deltopectoral groove. Which of the following structures would be encountered in the dissection down to the vessel? I think this is also a repeat question. It's a thoracoacromial artery.
Thoracoacromial artery through the deltopectoral groove. Exploration of the axillary artery. I repeat it from the last recall. Okay.
55-year-old man presents to the emergency department after collapsing. On examination, his pulse is 124 beats per minute, blood pressure is 60/30, and respiratory rate is 34 beats per minute. And his peripheries are warm. What is the most likely diagnosis? This patient is hypotensive and tachycardic and tachypneic, and he's warm. So this all points to sepsis, septic shock.
Okay, the other, if he didn't mention that he's warm, what you expect to be also in differential diagnosis?
Neurogenic shock? No, that would be bradycardic. Anaphylactic?
Anaphylactic, why hypotensive?
No.
Yeah, he was so hypotensive like this, and he has okay, hypovolemia, but they have to mention. Yani, I'm not confused.
Oh,
but,
yeah.
Some patient tachycardia, hypotension, but with any accident or loss of blood. So maybe this is hypovolemic shock or hemorrhagic shock. This is both are the same. That's why it is completely wrong. If you choose hemorrhagic, you'll choose hypovolemia. But this patient, as he told you, this picture plus cold, warm extremities, so this patient will have sepsis. Okay.
Okay.
I have some confusion about septic shock.
Yeah.
The parameters exactly. The heart rate is. I want to be more clear. This, the heart rate is increased. Okay. The cardiac output is decreased or increased.
Cardiac output decreased or increased in septic shock. Okay, but see, here it is out of your scope because it is initially increased due to tachycardia, and with peripheral vasodilatation will be decrease the venous return because increase the blood pool in the peripheral blood vessels. So in spite there is tachycardia, the cardiac output will be decreased.
Okay. The resistance is decreased. Systemic vascular resistance decreased.
Decrease in the systemic vascular resistance, but in sepsis, start first with tachycardia. Patient have sepsis. First, we'll start the patient with tachycardia. Okay, so the cardiac output will increase till this patient has peripheral loss of systemic vascular resistance. So the blood vessels on the periphery will dilate and will draw blood, and so the venous return will decrease. Okay, venous return decrease, cardiac output will decrease. Got it?
Can you say it again? The problem with sound.
Okay.
Only the septic shock. Okay.
Patient with sepsis. Sepsis infection. First of all, has tachycardia. Tachy. So increase cardiac output. As the sepsis progressed and the patient went in the septic shock, there is loss of systemic vascular resistance. So peripheral circulation will be dilated. So So the blood will be shifted to the peripheral circulation. Venous return will decrease to the heart because the blood is in the peripheral circulation. What makes the venous return good to the heart? The systemic vascular resistance. But when losing the systemic vascular resistance, okay, after I lose, I have the blood vessels like this. Okay, I found the blood vessels like this. So the blood will be pulled to the peripheral circulation. So the venous return will decrease. So the cardiac output will decrease. So initial, there is increase the cardiac output. But this is just a temporary and a very short time, followed by decrease cardiac output in spite of tachycardia. In spite of tachycardia. That means that the stroke volume.
Tachycardia remains, but cardiac output and venous return decreases.
Yes, because the stroke volume will be so decreased. The stroke volume is so decreased. You know that cardiac output is the stroke volume in the heart rate. Yes, the heart rate is still high, but the stroke volume is very low. So the end result, will be decrease the cardiac output.
Can I make a point here?
Yes, okay.
Yeah, so this is how I remembered sepsis. I also had a lot of trouble remembering sepsis. So sepsis is different to all the other kinds of shock in a way that sepsis starts with the blood vessels. Both the veins and the arteries are dilated. So now you have less pressure in the venous side and the arterial side. So the heart tries to work more harder. That's why it tries to increase the cardiac output and increase the heart rate. But it cannot compensate. I mean, compared to other shocks, the heart can compensate in the beginning at least. But in septic shock, the heart can't compensate because both the arteries and veins are dilated. So
exactly.
So the blood is not coming to the heart, and also the pressure is not being maintained in the arteries. So the heart gets tired very quickly because of that.
Exactly. Thank you, Dr. Fiji. Okay. Okay, so clear here. I think I don't want to go just more detail. Really, all these details you don't need to know, just to understand and forget about it. Low it, okay. Warm and dry. Okay. You have,
Because
okay.
I've made note of just writing the arrows, which is increases, decrease. That's why in case of sepsis, I was confused at what to write.
Question with arrows. Put in your mind what you will search for, and then search for it. I'll search for a heart rate increased, a cardiac output decreased, and systemic vascular resistance decreased, and then go to the arrows and go to the table to change what in your mind. Don't read the whole table, okay?
Yes.
Okay. Yeah, another trick thing, if you need some tricky thing. Okay, you have two shocks with warm hands. Neurogenic shock and septic shock. Both of them you have warm hand, but this is warm and dry hand, and this is warm and sweaty. And this is low heart rate, bradycardia, and this is tachycardia. But both of them, sometimes, yeah, this use tricks in our master degree asking about, okay, patient with shock, and you put your hand on his hand and found his arm is warm. How to differentiate what type of shock you have? Okay, tell if the hand is dry, so it is neurogenic shock. If it is sweaty, so it is septic shock. If the patient is bradycardia, mostly it will be neurogenic shock. If the patient is tachycardia, it will be septic shock. It's out of our scope, and thank you. Okay, continue. Next question.
In the posterior lateral approach to a posterior malleolar fracture, An incision is made between the calcaneal tendon and the distal fibula. Which of the following structures is at risk? Deep peroneal nerve, saphenous nerve, superficial peroneal nerve, sural nerve, tibial nerve. Since this is at the lateral side of the foot, it would most likely be the sural nerve.
Okay, sural nerve. Okay, postolateral approach, posterior malleolar fracture. Incision is made between the calcanea, tendon Achilles, and the distal fibula at the lateral malleolus. Which of the following structure will be at risk? The sural nerve. Okay, we have to. This is the lateral malleolus. Okay, this is our lateral malleolus, and this is the tendon Achilles. Between them, you have the sural nerve. Okay, anterior to it, you have the superficial peroneal nerve, which is this one. Anteriorly, saphenous nerve is not away from here. Saphenous nerve, it will be on the medial side of the knee. Tibial nerve will be posterior, and then the peroneal nerve away from here, the other side. So sural nerve just between the lateral malleolus and the tendon Achilles. If just anterior to the lateral malleolus, it will be the superficial peroneal nerve. Okay, if just anterior to the lateral malleolus, it will be the superficial peroneal nerve between an approach between the tendon Achilles and the lateral malleolus or the distal fibula. This will be the sural nerve.
25-year-old woman undergoes, an elective right thoracoscopic procedure for treatment of right palmar hyperhidrosis. Diathermy is applied to the neural structure lying anterior to the neck of the right first rib. What is the most likely complication to occur as a result of this procedure? So the diathermy to the neck of the right first rib is going to target the T1 nerve root, the stellate ganglion, and this will cause Horner syndrome.
Exactly. Next question.
A 33-year-old old man presents to the orthopedic outpatient clinic with a 6-month history of low back pain radiating to the lateral aspect of the left upper thigh. Micturition and defecation are normal, but there is no history of previous injury. On examination, left lateral flexion of the spine is limited, but a full range of hip movements are observed. Although it is painful, sensation is altered over the front of the knee. Left knee reflex is reduced, which spinal nerve is most likely to have been compressed. I used to think that the sensation to the front of the knee is L3, so I would go for L3. Like, I don't know.
This is L3, yes. No, this is L3. We changed it last time. Okay, you have 2 questions about this one, okay? One question, you tell the strange sensation in front of the knee and the knee reflex. The knee reflex is mainly L3, L4, mainly L3. But you have 2 sensations. Front of the knee, it will be L3. You have another question with loss of sensation on the medial aspect of the knee and the upper leg. And this is L4. Medial aspect of the leg or he's talking about the distribution of the saphenous nerve on the medial aspect of the knee and the leg, L4. So it will be L4. I think this question in past test or MRCS, I can't remember exactly, but you can choose between L3 and L4 by the loss of sensation. And the anterior of the knee, it will be L3, front of the knee. If on the medial side of the knee and the upper leg or in the leg, it will be L4. Because it's mainly L3, L4. And both of them, he tell you reduced knee reflex, but not lost knee reflex, because the another route is working.
Okay.
Clear? But mainly L3. Okay, next question.
25-year-old motorcyclist is admitted following a road traffic accident, having sustained bilateral femoral fractures and a ruptured spleen. 3 days postoperatively, Lai is noted to be confused, hypoxemic, and difficult to ventilate. His observation shows a blood pressure of 120/80, regular pulse of 88 beats per minute. He is apyrexic. Chest X-ray shows bilateral diffuse lung infiltrates. What is the most likely diagnosis? Since this patient has bilateral fractures, his blood pressure is okay, but I'm confused between pulmonary embolism and ARDS.
Okay, no problem. You just go together and try to think about you. Think pulmonary embolism. Okay, what's the new scenario come with pulmonary embolism?
A person that is, and he came after a fracture. Oh.
Okay.
DVT.
3 days ago. Noted to. So you said fracture, come after fracture, and come after DVT. It is a mandatory. I'm telling you, we are searching here for symptoms and signs for pulmonary embolism.
Can I say?
It should be tachycardic.
Can I say?
Okay, wait. Just I'm discussing with her to know how should she think about this. Okay, pulmonary embolism. Okay, chest X-ray showed bilateral diffuse lung infiltrates. What do you think about
lung
this?
infiltration is shown in respiratory distress syndrome mostly as pulmonary embolism.
Okay.
Yeah, it is seen more in ARDS.
Okay, what is the clinical picture of pulmonary embolism?
I think mostly they can be asymptomatic. They're radiographic chest X-rays.
Okay, an MRCS for basic students. He want to have the GMC registration for the basic medicine. He will not give you a pulmonary embolism with symptomatic pulmonary embolism. Even in part B, when there were patients, the patient, while you are examining him, he will shout, put his hand on her chest, and start to gasp. He's simulating, yeah. Okay.
Yeah.
So you will never see silent pulmonary embolism in your MRCS, part A or part B. You will have the classic picture of any disease, you know. The classic picture of pulmonary thromboembolism is chest pain, hypoxia. I give you the oxygen, give you chest pain, give you the patient has a swelling in his lower limb. Okay, he will give you the patient is hypotensive and the tachycardic.
Okay.
This is the picture of pulmonary embolism. Do you have anything of this picture here?
No.
And sometimes he tell you the patient has a low-grade fever. Like I think in 2021, patient with low-grade fever. Okay.
Okay.
So this is the picture of pulmonary embolism. Let's go for ARDS patient. Road traffic accident, sustained bilateral femoral fracture. This patient lost about 1.5 liters in each leg because the femoral fracture is about 1.5 liters loss of blood. So this patient received the blood. 3 days post-operative, he is noted to confused, hypoxic, and difficult to ventilate. This patient is difficult to ventilate. He has resistance to ventilation. That's why in patient with ARDS, we have to give positive end expiratory pressure to open the alveoli because this patient has resistance to ventilation. Okay. And his observation and the blood pressure show normal blood pressure. So this patient have nothing in his vascular system, normal blood pressure. In patient with pulmonary embolism, he will be hypotensive. Frankly, classically, he'll give you 90/60. Regular pulse of 88. This patient is not tachycardic. So the problem is not in the vascular system, and he is by apyrexic. Chest X-ray, bilateral diffuse lung infiltrates. So this is a classic picture of ARDS.
ARDS.
Or pulmonary edema, but this patient don't have pulmonary edema. No other things of pulmonary edema. Sometimes pulmonary edema give you this picture, but very rare to bring it for you in MRCS. He likes to fix in your mind that bilateral pulmonary infiltrates equal ARDS. Clear?
Okay.
Okay, this ARDS.
On an ultrasound scan of the popliteal fossa, when investigating a swelling, which of the following structures is closest to the capsule of the knee joint? It's the popliteal artery. It's the deepest structure.
Okay. Yeah, the next two questions, and we'll take break for 10 minutes.
Okay. A 25-year-old man sustains a twisting injury while playing football. He develops immediate swelling of the knee, and he cannot continue the game. 6 months later, he is still not able to play football. His knee feels unsteady and tends to give away. On examination, he has a full range of knee motion. There is positive anterior growth test and a small effusion. What is the most likely structure damaged? Since there is immediate swelling of the knee and there is positive anterior draw test, this is anterior cruciate ligament injury.
Okay, this is a classic picture of anterior cruciate ligament. Cruciate ligament have immediate swelling, and the patient, he will tell you the patient can't continue walking, can't continue playing, and so on, and immediate swelling. And then he will give you his knee gave away or unsteady. This is picture of anterior cruciate. Rarely he bring posterior cruciate, but you have to know. And he will tell you positive anterior drawing cyst is positive. So it is anterior cruciate ligament. I think in January 2021, he told his left leg lies posterior than the other leg, more posterior to the other leg, means that when he put his legs just beside and bend his knee, you will find the tibia is more posterior than the tibia is more posterior than the other tibia. So this is posterior cruciate ligament. So this is anterior cruciate ligament. Okay.
Okay.
Anyone has any debate about this ligament? Okay. Last question and then take a break.
A 62-year-old man required should we stop?
No, continue.
A 62-year-old man required a partial gastrectomy for a large benign ulcer in his gastric antrum. When he's reviewed in clinic 6 months later, he complains of palpitation, weakness, and sweating, along with cramp-like abdominal pain, which occurs within an hour of eating a meal. Usually, he has to lie down 30 to 40 minutes until the symptoms subside. What is the most likely cause of this symptom pattern? Since this patient underwent a gastrectomy, this is features of dumping syndrome, the highly osmolar chyme that enters to the small bowel is going to cause the fluid shift from the intravascular to the lumen, and this is going to cause the symptoms of hypertension, which this patient is having, which is weakness, palpitation, and sweating. This is early dumping syndrome.
Okay. If you find in the exam dumping syndrome, go for it. If you didn't find it, so you'll find one of the dumping, so high insulin or late dumping and early dumping and hypotension or something like that. But most questions in the exam, he will give you frankly dumping syndrome. He don't want from you to differentiate between early and late dumping, except if you want to ask about the mechanism of late dumping, which is
hyperinsulinemia.
For hyperinsulinemia, exactly. Okay. Okay, back again after our break. Start with question 63. Okay, Dr. Wagiha, you can start.
Okay, 63. In septic shock, noradrenaline is used to increase the systemic vascular resistance. This action is a result of the stimulation of which of the following receptors? So answer here is alpha-1, because for since we recently discussed on a message that noradrenaline for alpha-1 and epinephrine for beta-1.
Okay. As we said yesterday, this is a repeated question from yesterday.
Yes.
We have most important is he will ask you about the types of shock and what to give, and sometimes he asks you about what is the receptor, especially in septic shock. He asks about norepinephrine, which will mainly act on alpha-1 as a vasoconstrictor, as the main problem in septic shock is loss of systemic vascular resistance, decrease for systemic vascular resistance. Okay, the other two types is in anaphylactic shock, will give epinephrine or adrenaline. Sometimes he tell you adrenaline, and the other one is cardiogenic shock. We give dobutamine as the first choice. Okay, next question.
64. A 56-year-old man present with acute epigastric pain and vomiting. On examination, he has guarding in the upper abdomen. His test results shows serum amylase 900 international unit per liter. Gamma GT is 500 international unit, and triglycerides is 2.9 millimole per liter. They all are on the higher side. So which of the following most likely the etiology of this condition? So the answer here is alcohol, alcoholic pancreatitis, because amylase is quite high along with gamma GT.
The amylase is high. Pancreatitis.
Yes.
Okay, let's go for this question. This patient with acute gastric pain and vomiting examination. We have high amylase, we have high GGT, and we have high triglycerides. Liver function tests are unremarkable, a little bit increase, and we said this is almost normal. So we have to think this is a case of serum amylase high. This is a case of pancreatitis. Okay, this is a case of pancreatitis. So we have many types of pancreatitis. We saw before. We have alcoholic pancreatitis. We have pancreatitis due to hypercalcemia. Okay, if I have here hypercalcemia, but lucky I don't have it, so it will be confusing to me. How could I differentiate between it and alcoholic pancreatitis?
They will give calcium amount in the blood.
He will give you the calcium. This is first thing. The other thing is
there is another question in the same manner. They give the calcium we discussed in the position 1.
Yes, exactly. He will give you the calcium level. He will give you the calcium level. But I want to confuse from the lab test. It is hypercalcemia. If I don't have the calcium, it is hypercalcemia, or it is alcoholic pancreatitis.
Parathyroid.
Okay. GGT. Okay, so GGT, if it is high, that means there is liver cell injury. Liver cell injury. And at the same time, triglycerides are high in alcoholic patients. So pancreatitis. 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 I have two. Pain causes in part A and part B are the most common cause you'll be asked about. You have the alcoholic, and you have the hypercalcemia. Hypercalcemia, he will give you in the scenario the calcium level, which will be high. So it is a cause of pancreatitis. In alcoholic, he will give you GGT. Gamma glutarate transferase. Okay, and this will be high GGT high GGT is pathognomonic. Here for it is liver cell injury and also triglycerides are high. Both of them can tell you this is alcoholic pancreatitis. It is not cholestasis, not obstructive. If there is cholestasis and CBD obstructive jaundice, so sometimes obstructive jaundice come with picture of pancreatitis as well due to obstruction of the stone at the ampulla of water, so will obstruct the pancreatic and the biliary channel. So you will find all these high. Alkaline phosphatase will be so high. Cholestasis, the alkaline phosphatase will be high. Not this, sorry, alkaline phosphatase will be high. If the complication of pancreatitis is cholestasis, okay, the alkaline phosphatase will be high. Very important. So we can add here if this is the cause, if it is a stone. So I should have a picture of obstructive jaundice. So I will have high bilirubin, and I'll have high alkaline phosphatase. Okay. Clear the three main causes of pancreatitis? Clear?
Yes, sir.
Okay. Okay. From where? Okay, another question just to remember it. Alkaline phosphatase high. What is the main sources for alkaline phosphatase?
Biliary tract, bone.
Sorry?
Bone.
Muscle and the bone.
Biliary tract.
Bone and biliary system. This is the most common, by the way. The most common. And they like it to know. Okay, so if you have bone damage, alkaline phosphatase will be high. If you have biliary insult, the alkaline phosphatase will be high. Another one, yani forget about it. Just keep it in mind. There is another called placental alkaline phosphatase, and this is high in the this is a placenta high in patients with a remnant of placenta sometimes, or sometimes with cancers with placental origin related with placenta related cancer that happens in females sometimes. Okay, but forget about it. This is just high, not so common. Okay, keep with this in our schedule. Okay. And even this will be for part B, but just I want you, if alcoholic GGT will be high, if cholestasis, bilirubin, and alkaline phosphatase and liver enzymes will be high. If it is hypercalcemic, it will give you high calcium level. This is in brief. Okay, next question.
A 47-year-old woman with end-stage renal failure requires an elective cholecystectomy for symptomatic gallstones disease. Her hemoglobin preoperatively is 7.2 gram per deciliter. What is the major cause of her anemia? So answer here is erythropoietin deficiency.
Erythropoietin deficiency, okay. End-stage renal failure requires elective cholecystectomy for symptomatic gallstone, and then her hemoglobin is this. Because the major cause is erythropoietin deficiency, and this reminds us with the picture of renal cell carcinoma. Okay, you remember the paraneoplastic syndrome of renal cell carcinoma?
Yes.
Polycythemia.
Polycythemia.
So polycythemia due to increase in erythropoietin production in renal cell carcinoma. In patients with end-stage renal failure, they have a failure or decrease in erythropoietin, so they will have and anemia. So here is polycythemia and here is anemia. This is the two questions about erythropoietin you have in your schedule. Next question from yesterday.
60-year-old man undergoes cystectomy, bladder carcinoma. During surgery, the ureter are identified. On which region of the bladder do the ureter pierces the bladder wall? So it's the posterior surface or the base of the bladder.
Base or posterior surface of the bladder. The ureter is open at the base of the bladder or the posterior surface of the bladder?
Yes. 65-year-old man had a colonic resection for carcinoma 12 hours ago. He is now passing concentrated urine at the rate of 0.5 ml per kg per hour. Which endocrine response is most likely to have caused this? So the answer is increased vasopressin release, ADH.
Okay, post-operatively antidiuretic hormone increase and the post-operative stress, surgical stress. So it will be responsible for the water preservation and concentrated urine.
Yes.
Okay, next question.
28-year-old man presents with rectal abscess, where the abscess cavity likely to be sited. So answer here is medial to the pudendal canal.
Okay, this is the rectal cavity and this is the pudendal canal. So it will be medial to the pudendal canal. Medial to the pudendal canal. Next question from yesterday.
Yes, a 36-year-old man falls on his outstretched right hand. Examination revealed tenderness in the anatomical snuff box. Which one of the following tendon form a boundary of the anatomical snuff box? Form a boundary of. So the answer is extensor pollicis longus. Sir, here it is not mentioned which boundary.
Okay, here is fold an outstretched hand. The examination revealed tenderness in the anatomical snuff. Which of the following tendons form a boundary of this? So okay, the only boundary is
extensor pollicis longus.
Exactly. What other here? We said what is the boundaries of the anatomical snuff box? Extensor pollicis longus medially or posteriorly. Make it medially. Extensor pollicis longus, which is this one, and then the lateral or the anterolateral boundaries are the extensor brevis and the abductor longus.
Yeah.
Abductor longus, not brevis. Abductor longus and extensor brevis. Okay. One extensor longus. So the extensor, just to remember it, on the two sides. You have two sides only. Okay.
Yes.
You have two sides only. Longus on one side, and it's brevis on the other side, which is the extensor pollicis longus, extensor pollicis brevis, and the abductor longus. Okay, so the only one right is here is extensor pollicis longus.
Yes.
Clear? Concentrate in the exam. In the exam, stress of exam, you'll be confused. You have two extensors, the longus and the brevis, and you have one abductor, which is the longest.
Yes, abductor is the longest. Abductor longus and extensor pollicis longus.
Okay.
And extensor pollicis brevis. Yes, sir.
Clear?
Yes, sir.
An extensor, two extensors and one abductor longus. The two extensors, the longus and the brevis. Okay. and then add to the brevis, add the abductor longus. Okay.
Yes.
Continue.
A 55-year-old woman complains of cramps and tingling in her legs and arms 48 hours following subtotal thyroidectomy. Her vitals are stable, and investigation revealed normal white cells counts, and normal hemoglobin. The sodium is 132 millimole per liter, potassium is 3.2 millimole per liter, and calcium is 1.60 millimole per liter. Serum albumin is normal. The next appropriate step is intravenous infusion of. So answer here is calcium chloride, because maybe during the procedure of thyroidectomy, parathyroid hormone is removed.
Okay, sometimes there is transient decrease and not removed. Okay. Sometimes there is transient decrease in parathyroid secretion after the operation due to excessive dissection or relative ischemia, which will be back normal within 1 or 2 days. Okay. But if there is critical decrease in the calcium, you have to protect the heart with calcium gluconate, which is the first choice. If you didn't find calcium gluconate, you can go for calcium chloride. Okay. Calcium gluconate is the first choice. If you didn't find calcium gluconate, go for calcium chloride.
Okay, sir.
Hypocalcemia. The first treatment is calcium gluconate. If you don't find, it will be calcium chloride. The first treatment for hypercalcemia is
normal saline.
Normal saline infusion. Normal saline infusion. Hydration of the patient. Hydration of the patient. Normal saline in ACL infusion. Okay, so hypocalcemia, calcium gluconate or calcium chloride. Hypercalcemia is NaCl or hydration of the patient. Next question.
40-year-old woman presents with fecal incontinence and anatomical intact internal and external anal sphincter. Which structure is most likely to be damaged? Fecal incontinence. So answer here is the pudendal nerve, because pudendal nerve supply, yeah.
Okay, root value.
S2, S3, S4.
Sorry?
Sir, S2, S3, and S4?
S2, 3, 4, exactly. S2, 3, 4 gives the external anal sphincter and external urethral sphincter as well. Next question.
Abdominal free fluid will collect in the lowest part of the peritoneal cavity at operation with the patient supine. In which of the following will the fluid collect first? It's hepatorenal pouch, left subphrenic space, lesser sac, right paracolic gutter, or right subphrenic space. So answer here is hepatorenal pouch.
Hepatorenal pouch. The most common 2 places for any collection in the body is the pelvis or Douglas pouch, sometimes in female, and the Morrison pouch or Morrison or hepatorenal pouch. Morrison or hepatorenal pouch. In patient in Fowler's position or semi-sitting position, and this is sometimes when you do exploration or any operation, we always like in our doctor orders, put the patient in semi-sitting position. Put the patient in semi-sitting position, so the patient, any collection will go for the pelvis, or here go to the pelvis or Douglas pouch or so. If the patient in a supine position for any cause, he has possibility to have collection here and collection in the hepatorenal pouch or Morrison pouch. That's why he tell you here in the supine position. If he tell you in the semi-sitting position or Fowler's position, and this is the favorite position for any surgeon, so all collection here. That's why we always put our drain here. And sometimes if the patient, we can't say it for any other problem, maybe orthopedic problem, we put a drain in the Morrison pouch, especially even after cholecystectomy. Sometimes we put a drain in the hepatorenal pouch. Okay.
So, sir, if it's in the so if the patient is in Fowler's position, so the fluid will collect in which space? Sorry.
Pelvis. Fowler is a semi-sitting position, so all the fluid will track in the pelvis. Okay, but never came before. But it is common with our surgical work. The other is patient is hepatorenal here. Hepatorenal or Morrison pouch in patient, he will tell you supine patient. So very common to collect here. Okay, next question.
A 45-year-old homeless man presents with a cough and weight loss over 3 months. On examination, his BMI is 19 and he has reduced breath sounds in the right upper zone. The chest X-ray shows cavitating lesion in the right upper loop. He undergoes bronchoscopy and bronchial biopsy. The biopsy shows the feature of necrosis surrounded by epithelioid macrophages in the giant cells. Which of the following is most likely diagnosis? So the answer here is tuberculosis.
What's your differential diagnosis here?
So first would be
okay. What is the cavitating lesion in the lung? Peripheral cavitating lesion. Okay, answer is tuberculosis, right? Why? What is your key answer here?
So because of the biopsy finding, firstly, because of the epithelioid macrophages in the giant cells. Secondly, the history shows that he's homeless.
This is the pathology, pathognomonic for tuberculosis. Okay, yes. Or tubercle granuloma. Tubercle granuloma, epithelioid macrophage and giant cells.
Yes, sir.
Okay, another scenario, you have patient who is presented with cough, weight loss, and the cavitatory lesion on the right upper lobe or on the upper lobe of the. What else will be for the patient? Can be squamous cell carcinoma. Squamous cell carcinoma is one of the most common cavitatory lung peripheral lesion. Cavitatory lung lesions. We will have 2 questions about this soon. And according to the scenario, if he told you featureless necrosis surrounded by epithelioid macrophage and giant cells, or patient come from endemic area with tuberculosis, patient coming from India, from Bangladesh, from something, any area, and after he came, the patient has some fever, cough, weight loss, and he didn't even mention this, and sweaty. This patient mostly will be tuberculosis. If the patient has cancer, as we agree, he will give you some picture about cancer, or sometimes he will tell you sputum analysis has keratin-like cells. Okay.
Keratin pearls.
Like
keratin pearls is. So keratin pearls or keratin bridges is the pathognomonic for the squamous cell carcinoma.
Keratin. I can remember the scenario. It will be keratin-like or keratin cells.
Both are.
Yeah.
Both pearls and bridges are pathognomonic.
What?
Thank you.
Sorry, repeat again what did you say? I can't hear you.
Yeah, both keratin pearls and keratin bridges, both are pathognomonic for squamous cell carcinoma.
Exactly. Yes, exactly. So these 2 scenarios about a cavitatory lesion, and almost all the age of the patient will be above 60 or 70. Will not be a young patient like this. So age of the patient and the pathology of the sputum or the mass will give you this picture. Put in your mind that squamous cell carcinoma is one of the most common cavitatory lung lesions. Okay, next question. I think repeated yesterday.
Yes. A healthy 36-year-old man is being assessed with a view to being a life-related kidney donor. Which are the following investigation is most accurate to measure the GFR? So the answer here is inulin clearance.
In your case, we agreed since yesterday, glomerular filtration
Yes.
rate, inulin clearance, and plasma, renal plasma flow is
pH, PA,
Para-aminohippuric acid.
sorry?
Para-aminohippuric acid.
Exactly, para-aminohippuric acid. Para-aminohippuric acid. So glomerular filtration rate, inulin clearance, and glomerular filtration rate with inulin clearance. Okay, next question.
A 34-year-old pregnant woman developed swollen leg. Her mother and maternal aunt also had the similar problem during their pregnancy. Which of the following tests is likely to be positive? So the answer here is antiphospholipid antibodies.
Antiphospholipid antibodies is very common in patient, pregnant lady, 13th pregnant lady had recurrent abortion or recurrent DVT. Recurrent abortion or recurrent DVT in a pregnant lady, which will be, and also you see here similar problem during their pregnancy. So this is antiphospholipid antibodies. Antiphospholipid antibodies. This question will come in your exam because this question in every exam. Okay, you see it in Fawzia 1 and Fawzia 2. This question will come in your exam. Next question.
A 72-year-old alcoholic man is known to suffer from chronic obstructive pulmonary disease. He has now been diagnosed with carcinoma of the urinary bladder and has a history of gastric ulcer. Which of the following agent is most likely to be responsible for all these problems? So the answer here is cigarette smoking.
Okay, so cigarette smoking and is a common risk factor for both urinary bladder and gastric ulceration. Okay, thank you, Dr. Who else? Dr. Rabiha, thank you. Who next? Dr. Khadiza. Dr. Vijay, okay. You didn't say anything today. Okay, continue the next 13 question or 14 question.
Sure.
Okay, Dr. Munira and Dr. Khadija, let Dr. new participant to participate today. Just take the courage to answer question. Okay, continue.
Okay.
Yeah, so I can continue, right?
Yeah. Okay, Dr. Vijay. Yes, I'm saying it right. Yeah, Vijay.
Yeah, you're saying it right.
Okay, continue, Dr. Vijay.
So, a 3-year-old boy is admitted to hospital with severe vomiting. Radiographic examination and history reveals that he's suffering from annular pancreas. Which of these structures is constructed? Okay, so annular pancreas, that means the pancreas is squeezing the duodenum. First, second, third. Okay, so it would be second, as first is too early, third is too distal. Mostly
yes, this is the second day. This is and if you went for the abdominal lecture, you'll find this is very common, and this is repeated since yesterday. Annular pancreas around the second part of the duodenum.
Yeah.
Constrict the second part of the duodenum. Okay, next question. Repeated also. Continue.
Okay, so a 45-year-old man presents with a 3 × 4 centimeters swelling in the right groin, which is non-tender. A cough impulse is elicited. At operation, an indirect inguinal hernia is found. The external inguinal ring is a defect in which of the following muscles? Okay, so external inguinal ring. Okay, so Extralingual ring is, I think it's made up of only one muscle, so it's gonna be external oblique. Okay, external oblique aponeurosis. Yeah.
Okay. We have two important questions at this point. Okay. One of them, what is the opening of the external ring? Opening of the external ring, this is the cord. Okay. Opening of the external ring in the external oblique muscle. Opening of the internal ring is in the
Transverse fascia.
Fascia transversalis or transversalis fascia. Okay, so this is the internal ring and this is the external ring. Okay, this is simply the two questions about the rings and where they open. Okay.
Yeah.
Next question.
45-year-old woman suffers from spina bifida and is confined to a wheelchair. Her legs are not fully developed. What is the pathological process which has occurred in her legs? Okay. Yeah, so that would be hypoplasia. Right?
Hypoplasia, exactly. Yes. This is not apoptosis, not atrophy, not hyperplasia, not hypertrophy. This is hypoplasia of the legs. Hypoplasia of the legs.
So usually spina bifida is something that's seen in pediatric patients, right? It's seen at the birth.
Yes, sometimes. So, yes.
Yeah, so she's 45 years old. Like she had it, she did not take any treatment, or that's the only way possible, right? Or adults can also get it.
No. This is spina bifida is a congenital problem. Congenital problem. Born with it. Incomplete closure of the spine. But this is out of scope. What we need here is about this. And also we will face question about spina bifida as well. Types of spina bifida. Okay, next question.
A 23-year-old man presents to the emergency department with non-specific chest pains. A PHS radiograph is performed and is normal. Immediately inferior, caudal to the outline of the aortic knuckle, was a farther structure with a convex border. Okay, what is this structure? Immediately inferior caudal to the outline of the aortic knuckle. Okay, so the aorta goes like this.
Very simply, because we are surgeon. This is aortic knuckle. If you are seeing the normal X-ray, you remember when we are studying in the 4th year or 6th year, this is the knuckle. You have the aortic knuckle, and below it you have the pulmonary trunk, and then the left auricle, and then the left border of the heart. So aortic knuckle, here is very nice photo. This is aortic knuckle or the aortic arch, followed by the pulmonary trunk, followed by the left auricle. But always you ask about this. Okay.
Yeah.
Pulmonary trunk. Yeah. Some of the silly questions.
All the other structures you don't see it in an AP view, right? The esophagus is behind, the right atrium is completely to the.
It's out of our scope, Dr. Vijay. This is out of our scope. This question, by the way, may be repeated one time only before, because this is mainly not a surgical question, mainly a chest question and the MRCP question. But sometimes we face sometimes you want to put new question. It's yes, related to our work, you have to know something like this. But this question, maybe I saw it one time after Fawzia sheet. Not more, but you have to know it. Very simple. Don't put new question, don't new more explanations. Just know that after the aortic knuckle, you have the pulmonary trunk. That's all. Okay. Try to be stuck to very minimal information in front of you. Yeah, next question.
So a 45-year-old woman presents to the hospital with jaundice. She undergoes ultrasound scan and is diagnosed with hepatocellular carcinoma, affecting the left lower lobe of her liver. Which virus is the most likely to be implicated? Okay, so carcinoma, it's hepatitis B. Okay.
Yes.
Yeah.
Hepatitis B is much more than hepatitis C in causing hepatocellular carcinoma.
Yeah.
Even if you find hepatitis C here, yeah.
I remember C for cirrhosis.
Both of them make cirrhosis. Both of them make cirrhosis. But vitamin C to make hepatocellular carcinoma, it needs more than 20 years to develop hepatocellular carcinoma.
Yeah.
But in virus B, very rapid patient can develop hepatocellular carcinoma. Okay, next question.
Next, an 82-year-old man has complete occlusion of his inferior mesenteric artery on angiography, but no symptoms or signs of colonic ischemia. Okay, which of the following arteries is the most likely additional source of the blood supply? So
we said this yesterday.
Yeah. So which artery? Inferior mesenteric. Okay, so IMA occlusion. So there is SMAM anastomosis. So it should be a branch of the SMA. So D and E are not. Then gastro A is also not. That's celiac trunk. B, yeah, only C is left. Middle colic.
Okay. We said yesterday, keep simple that the middle colic artery has anastomosis between the superior mesenteric and the inferior mesenteric. Whatever the scenario he will ask you about, he won't at the end of the scenario ask you what shares the blood supply and can give a blood supply to the left colon in case of inferior mesenteric nerve occlusion, or what is the anastomosis between, or what is the shared area between the superior mesenteric and inferior mesenteric, which is the middle colic artery share between the superior mesenteric and inferior mesenteric.
Yeah.
Okay.
Yeah. So actually, like, there's two ways I answer a question. Either I know the exact correct answer, or I remove all the wrong answers. And
yes,
then
exactly. You removed all. You removed all the celiac trunca, left gastric, splenic, superior rectal from the inferior mesenteric, left colic from the inferior mesenteric as well, and splenic and left gastric from the celiac trunk. So the only one from the superior mesenteric is the left colic or the middle colic, and this is very nice also solution by exclusion.
56-year-old man with documented type 1 diabetes presents to the surgical outpatient clinic with 3 months history of right leg pain brought on by walking 50 meters. He has no history of back pain. He has been a smoker for 10 years, 10 cigarettes a day. He states his alcohol consumption to be 30 units per week. On clinical examination, significant findings include weak right foot pulses with altered sensation on dorsum of the right foot. What is the most likely diagnosis from the following list? Okay, so this looks like a what you call ischemia to the leg. Because of the diabetes and smoking. So yeah, so that's B is the only option that talks about a blood vessel. So that's the possible.
In our schedule in part A and part B, and in even a big station in part B, you will have lower limb examination for a lower limb pain or a lower limb pain. Okay, you have two causes: vascular and neurogenic. In vascular, simply from the scenario, he have to tell you the patient has low back pain or not. The patient here is by exclusion, he told you the patient has no back pain. No back pain, so he excluded the radiculopathy. In neurogenic cause, he will tell you the patient has a low back pain. Okay, here is, he'll tell you the patient has picture of peripheral vascular disease. The patient is a smoker, the patient has diabetes mellitus, the patient has hyperlipidemia or dyslipidemia, and so on. So this picture of cancer. He will give you a picture of weak pulses. Here he will give you a picture of neurological deficits, weak reflex, joint weakness, paresthesia, and so on. So simply will be in the exam. All of this is neuropathy, this is neuropathy, this is neuropathy, this is neuropathy. The only one is vascular. The exam is so simple. The exam is so simple. And I don't want to tell that any stupid student can pass more than 50% of the exam by this way. Okay, patient have lower limb pain. He has lower limb ischemia. This is ischemia. Ischemia. So, but the patient has no back pain. He like is telling you, take care. The patient has no neurological symptoms. Okay, but I'll not tell you this. This is cheating. I'll tell you the patient has no back pain. Okay, the patient clinical examination, significant finding, and he can walk forward. Pulses are altered. Sensation.
I think this all is also not necessary. Just as the patient has pain only when the patient walks. That
exactly. Sometimes the patient walks and then with rest, patient walks has some pain. Sometimes it happens with radiculopathy. The main thing is in your big station in part B, if you want a patient with lower limb pain, okay, and you didn't ask the patient, do you have back pain or not? You lost many marks from FE. The mark is from 20, you lost about 4 marks from 20. You didn't ask, you didn't exclude the main differential diagnosis. You have to exclude this. Okay, I'm just preparing you to part B as well. Part B, big station, if you have the patient, you have to tell him the first, do you have a back pain? If he said no, okay, and the examiner will make like this. Good, perfect. He excluded the main differential diagnosis. In part B, you have to prove your diagnosis and exclude the main differential diagnosis. Okay? Yalla. We'll meet in part B, inshallah. Yalla. Next question. This is yesterday question.
Okay. 35-year-old man presents with a 3-week history of low back pain and 3-day history of pain and weakness in his left leg. Physical examination demonstrates numbness over the posterior aspect of the left calf, extending to the lateral aspect of the foot. Left ankle reflex is absent, and an MRI shows compression of the left S1 nerve root. What is the most likely structure compressing the nerve? I think, yeah, this nucleus pulposus. This is just too easy.
This is disc.
Hold everything.
Yeah, so easy. This is disc, nucleus pulposus. Okay, next question.
A 72-year-old man who is a smoker presents to his doctor with the second episode of frank hematuria. When an ultrasound scan of his urinary tract was performed, it's a solid lesion in the right kidney. What is the most likely pathology underlying the presentation? So you have frank hematuria, smoker, and there's a solid lesion. So that's renal cell carcinoma. Those 3 things. Yeah, you even make them green.
So
you just explaining, a couple of hours ago the same thing.
Yes, exactly. That I told you. This patient have a mass. This is
solid lesion, smoker, hematuria.
Exactly. Solid lesion in the right kidney, or solid, and sometimes in the loin. Okay. Yeah. So this is frank. So both of them, frank hematuria and smoker patient, can come with transition cell carcinoma or renal cell carcinoma, but with the from the history you can diagnose both of them. Okay, even here transition cell carcinoma.
Yeah.
And in renal cell carcinoma, sometimes he give you the labs and tell you, and this is the very most common, and give you the patient has hemoglobin 18 or 19 or something like this. Okay?
Yeah, because renal cell carcinoma has the erythropoietin, right? So more
Yes, exactly.
RBC.
Okay, next question.
20 years old man presents with abdominal pain and shock. He's found to have hemoperitoneum due to a ruptured spleen. He denies any history of trauma. What is the most likely predisposing cause of a splenic rupture? Okay, so no trauma. So it should be some kind of viral infection. In the options, only A makes sense. Okay, every other is not related to splenic rupture. I think in EBV, if a patient has mononucleosis, infectious mononucleosis, you advise the patient not to play any contact sports like football or something, because they can get ruptured spleen.
In your exam in part A and part B, spontaneous splenic rupture in young patient, or with splenomegaly, this is Epstein-Barr virus due to infectious mononucleosis. That's the end point. Okay, your mind, spontaneous splenic rupture, and very common in exam. It's repeated about 10 times before. Spontaneous splenic rupture is Epstein-Barr virus due to infectious mononucleosis.
Okay, so also because of malaria and typhoid fever, I did not know that.
Didn't come before. Didn't come before.
Okay.
Didn't come before. They like Epstein-Barr virus spontaneous splenic rupture.
Yeah.
Okay, continue.
A 30-year-old woman presents to the outpatient clinic with a 3-month history of diarrhea, which is intermittently bloody. On rectal biopsy, the histology has shown a granulomatous inflammation. Yeah, that's Crohn's.
Crohn's disease, 30, young, they like Crohn's disease in young patient. I tell you also, young patient, female or male, history of diarrhea, intermittent bloody, rectal biopsy show a granulomatous infection. Granulomatous infection. Okay, yeah. Crohn's disease. What is the definition of Crohn's disease? Pathology?
Crohn's is Th1 mediated.
Okay, part B, non-caseating.
Yeah, non-caseating.
Granulomatous. This is a gross picture. I need in part B tell you what is Crohn's disease. You have to say non-caseating granulomatous inflammation. Okay, you got the full mark.
Yeah, and you have skipped lesions in Crohn's, and in ulceration, ulcerative colitis, the lesion is continuous.
Okay, no problem with all this material. Keep with the question I'm telling you. This is young patient with granulomatous inflammation. This will be Crohn's disease. You have both here. Simply the difference between both of them. This is just transmural. This takes all the layers of the ileum, starting from mucosa up to the serosa and periserosal tissue as well. This is only the mucosa and submucosa. This is skipped region. This is continuous lesion, and so on. Next question and last question as well. And tomorrow we'll start from 89.
Okay. A 56-year-old motorcyclist presents to the emergency department after being involved in a road traffic accident. He's a smoker and known to have hypertension. He's conscious with a Glasgow Coma score of 13/15, maintaining his own airway and breathing. Found to have open right femoral fracture with normal distal pulses and sensation. Resuscitation is started. Okay. Urethral catheterization 250 ml immediately, but over the following 60 minutes, he drained only 10 ml. Which of the following is the most likely cause of the low urine output? Yeah, so it is hypovolemic because the kidneys are trying to save fluid because of the blood loss, right? Yeah, so no less urine is produced because to maintain the fluid volume in the vasculature.
Okay, you have two questions about patient hypovolemic or patient with a catheter and the patient have reduced. Okay, one of them, the patient will give 250, then over 60 minutes, the patient will give 10 ml, and so it's, and this type of urine concentration and hypovolemic shock. Okay, due to antidiuretic hormone and renin angiotensin aldosterone system. So the body trying to preserve water. The other scenario will tell you the catheter will give 80, 80, 80, then 0, 0, 0. This is blocked catheter. Most common cause of no urine in catheter or anuria with catheterized patient. Most common cause is blocked catheter. Okay. The most common cause of no urine in catheterized patient is blocked catheter. You have to think about this, because if you didn't think about this, you can do many investigation for the patient. Okay. And this is a very common station in Part B patient with a catheter and block. First thing, what will you do, doctor? I'll flush the catheter. First thing, I'll flush the catheter. And then if it doesn't get, I'll give fluid challenge. And then after fluid challenge, I start to think about other causes like hypovolemia, ultrasound. I refer the patient. I start to make CVP for the patient through central venous pressure and so on. But if you didn't mention blocked catheter and you give all the causes of anuria, and the doctor tell you, by the way, this patient has a blocked catheter, and no need to do all this investigation or examination. Okay.
Yeah.
Blocked catheter is the means.
So if it goes to 0 all of a sudden, it's blocked catheter.
This is blocked catheter. We will have this scenario in our discussion. Here are last two questions, so we can finish tonight to tomorrow to start from 9 to 1.
Okay. A 35-year-old man is admitted with pancreatitis, which leads to admission.
Hello?
Elevated respiratory rate, increasing hypoxia. Suspect is developing respiratory failure. Which of the following mechanisms is responsible for the regulation of respiration? Okay. Okay, so here the correct answer is B, but I think I would have selected D. I would have selected D.
Okay, which leads to admission to the surgical high dependency unit. After 48 hours, he develops breathing difficulties with elevated respiratory rate and increasing hypoxia. We suspect he is developing respiratory failure. Which of the following mechanism is responsible for the regulation of respiration? Okay.
Yeah, but see, I mean, from what I remember from physiology, CO2 doesn't directly cross the blood-brain barrier. So the blood pH is the indicator.
Central chemoreceptors. Central chemoreceptors are affected. By the way, we have doubt in this question since last time, because we are talking about central chemoreceptors. Okay. Central chemoreceptors. Okay.
Yeah, but the option says in medulla. So medulla comes inside the blood-brain barrier.
Yes, okay. I'm talking about central chemoreceptors.
Yeah, central chemoreceptors.
Okay. I'm talking about central chemoreceptors. We have two things. CO2.
So D
and pH.
D is also possible correct answer.
2.
Is D can also be correct answer?
D can be possible Correct answer, because the central chemoreceptors are affected by both CO2 level and pH of the blood. Central. The peripheral chemoreceptors are affected also by the low O2 level, plus the CO2 and the pH. However, last few years, all are answering it like CO2 concentration in the medulla, but I know many before convinced that hydrogen ion diffusion across the blood-brain barrier is also because this is
but in the real
the pH
exam
of the blood.
in the real exam I choose B, I get the mark, right?
Till now, all the recall since 2016 answering it CO2 concentration in the medulla. Okay, but it needs some one of physiology can help us in this again. Okay, let me think about this again, because I remember it from the last recall, and we just have a confusion about it. But we prefer, because of short time, we prefer to keep it like last, because many for 3 exams for about 4 years now, so about 12 exams concern about CO2 concentration in the medulla, as here also CO2, plasma CO2 concentration, chemoreceptor in the medulla oblongata, so it will affect. And here the pH is mainly chemoreceptor in the aortic and the carotid bodies, so respiratory center in the medulla oblongata. Mostly till now CO2, according to this algorithm.
Maybe because pH is indirect, like it has to go through the sensory neurons of the aortic or carotid bodies then to the medulla, but CO2 is direct from blood to the medulla, so that's why maybe
I go with CO2, but I can't exclude hydrogen ion diffusion across the blood. Okay, let's keep it like last few years CO2 concentration in the medulla, and according to this algorithm also that plasma CO2 affect CSF and chemoreceptor in the medulla oblongata will affect the respiratory rate. Okay.
Yeah. A 70-year-old man undergoes transurethral resection of the bladder tumor. The tumor lies above the lateral side wall of the bladder, just above the opening of the right ureteric orifice. Use of the diathermy suddenly causes the patient to kick because of the contraction of his hip adductor muscles. Okay, so which nerves is stimulated? That's obturator, obviously.
Obturator nerve,
all the other nerves are
abductors.
completely unrelated, yeah.
Okay, but this is also, he'll tell you, this patient you are to take use of the SRMI, he wants to ask you infect adductor muscle. Yeah. Because contraction of the kicks because of contraction of the abductor muscle. You have 2 scenarios about this scenario. You have 2 scenarios in the exam. One scenario is male patient and you are doing an operation in the bladder, or I'm doing an operation in the prostate, maybe the prostate TURP, and you touch a structure and it makes kick of the leg with due to contraction of the adductor muscles. It will be the obturator nerve. The other thing, a patient, you are doing an operation and she has an ovarian mass or an operation in the ovary, and during your operation you touch a structure and the patient kick due to a contraction of the adductor. So operation in the prostate or operation in the ovary, and you touch a structure with the diathermy and the patient kicks due to contraction of the adductor muscle. This is the obturator nerve in the pelvis. This is a 2 scenario about obturator nerve in the pelvis. Okay.
I think obturator nerve is the only nerve that passes through the pelvis, right? All the other, they don't even pass that close to.
Yes, exactly. But I'm just giving you the 2 scenario about this. The 2 scenario you will face in the exam. An ovarian operation, patient with ovarian mass or polycystic ovary or what, and you are doing an operation, or patient with prostatic or TURP operation will have this. This is the 2 scenarios very common in the exam. They are switching between these 2 scenarios. Okay, thank you for today. We finished up to 90 starting tomorrow. I wish we could finish today, but I don't know how we finished it last recall. We finished it in one set. This is about, we still have about 70, 80 more questions, or 85 also. Many of them are repeated, so we will continue tomorrow, inshallah, at the same time.
So doctor, you have the recalls also like this with diagrams and explained?